be invited to this lovely gathering of anesthesiologists to discuss on one of the most relevant and concerning topics today, and that is obesity. My sincere appreciation for Indian Society of Anesthesiologists and Thane Anesthesiology Society for organizing this seminar on obesity. Our sincere thanks also to Dr. Meenal Gadgil, Dr. Manisha, Dr. Nilima, and of course, my dear friend, Dr. Bhavesh Nanda, for having me here. Friends, obesity is a household disease. Changing lifestyles and eating habits have brought a drastic change in the health patterns of the individuals. Obesity is also a progressive disease, which shortens life expectancy and is associated with wide range of serious medical problems. Obesity causes physical, mental, medical, psychological impact on the life pattern of the person. The point of concern here is that every medical field, each and every medical field is affected by obesity. Any treatment that you do on an obese patient for your medical problem gets prolonged and the recovery pathway gets delayed if it's associated with obesity. It's not a coincidence, friends, that obesity is linked to almost 76% of diabetics, 72% of hypertensive heart disease patients, 60 to 70% of obstructive sleep apnea patients, 70% of hypertensive patients, 50 to 75% of infertility patients, almost 40% of osteoarthritis patients, and even 40% of cancers. Luckily, it's a reversible disease. And if the right decision is taken at the right time for the right patient, the results are amazing. It not only reduces the weight, but also helps in decreasing the medical problems and associated comorbidities which have come up because of obesity. Friends, we have been treating obesity since almost 2 decades now. And as rightly said, we are a center of excellence in bariatric surgery has been given to us since past 6 years now. And this is given to only 2 centers in Mumbai, and only 11 centers in India are currently centers of excellence. And we operate right from an 80 kg patient who should be 50 to a 377 kg patient, which is the highest that we've operated. But there is something we need to understand, that if there are, say, 20,000 patients in a year who are getting operated for bariatric surgery, there are more than 2 lakh patients who are obese and getting operated for something else but are obese. So the concerns of obesity, concerns of anesthesia, concerns of chest physician, and concerns of other consultants is always there. So challenge lies in those patients where the consultants are not treating them on a day-to-day basis. You can see, for case of a diabetologist has to treat diabetes. If a patient is obese, he's going to have more difficulty in treating the diabetic patient. If there's a physician who's treating hypertension, he'll have more difficulty in treating that hypertensive patient. The results will not be so prompt. If it's a chest physician treating obstructive sleep apnea, the results are not going to be so easy. The patient might have to go on a CPAP and things might be quite different. Similar goes for orthopedic patients and gynecology patients during deliveries and routine surgeries. But in case of surgeries where all other consultants are impacted in their line of treatment, I feel the most impacted is the anesthesiologist, as the major responsibility in every surgery lies with the anesthesiologist. Friends, very proud to say that we have done more than 6,000 bariatric surgeries till now. And we have always had only one team who has been with us strongly in our pursuit to cure obesity. Dr. Bhavesh Nanda, I'm very happy to say he's been our chief intensivist, chief anesthesiologist since past 19 years now. And we've had some and we've been having some amazing results. But friends, what is more important is that treating obesity is always a teamwork. And I have always felt that if 50% part is surgery, 50% part is all other consultants and all other team people apart from surgery. So it's very important that, yes, these patients are so many times compromised. These patients are so many times not so optimized on health. Their lungs are not so good. The heart is not so good. So what do? Just because the patient is coming, we go ahead and operate? No, that's not the way we should be treating these patients. We have been taking lots of care, and not just me, any and every bariatric surgeon in the country would take lots and lots of care in terms of pre-surgery optimization. in terms of involving the anesthesiologist before surgery, involving the nutritionist before surgery, having a lovely post-surgery protocol and post-surgery care. I'll tell you, more than 6,000 patients, and we have almost 95% follow-up of past 19-year patients also. So this is something that we need to do because we consider obesity as a problem. And if it comes back, then it comes back to revision surgeries and multiple other things, which we want to avoid as much as possible. Friends, it's always to take care of obesity first, and then the secondary problems that have arisen because of obesity. I'll give a small example of patient with osteoarthritis. And we've had umpteen examples of these patients who have been having osteoarthritis and they've been advised a knee replacement first, and they go for a knee replacement first. And then they have come to us 2 years and 3 years after knee replacement that obesity to tha, saath mein knee replacement kar diya, and the knee surgery has failed because the patient is as immobile as the patient was earlier. It is always important that please take care of obesity first. Take care of obesity, reduce the weight, increase the life of the implant, increase the quality of life post-surgery. It will make tremendous impact on your life and on your life transformation also. Take case of infertility. You know, if normally there is a patient who's obese, a boy, suppose before marriage, a boy is obese. Whatever said and done, जब तक अंबानी की बेटी नहीं, अंबानी का बेटा नहीं है, उसे लड़की भी obese ही मिलने वाली है. If the boy is obese, the girl is obese, the higher chances of infertility comes in. You know, when one partner is obese, there might be 50% chance of infertility. When both partners are obese, the chance of infertility might go out to 75% also. Then comes IVF and multiple IVF attempts, still giving hormones, still increasing obesity. So the cycle never stops. And probably that is not the best way to do it. And if in that place, a person gets operated and loses weight before getting married, you know, possibly you get a girl of your choice, of a lesser weight, all the complications of pregnancy related complications, infertility related complications can just get driven away. So friends, there might be many such more examples, but we seriously feel that obesity is the mother of all diseases today. And if obesity is treated in the right manner at the right time, it can lead to life transforming results. Though there are various surgeries possible, like a sleeve gastrectomy, a gastric bypass, a mini gastric bypass, revisional procedure, any of the procedures, if done to the right patient at the right time with right precautions, can lead to amazing results. A shorter stay, early return to work, very safe procedures. So one thing that each and every one of you all, though you all might have been either assisted the surgeries, done a few surgeries, been there for certain surgeries, or you all have possibly wanted to be a part of any bariatric team, friends, I and Dr. Bhavesh could definitely like to invite all those who would like to be a part of or witness a few surgeries at our place. Please come down. It's a daily process, Monday to Friday, 1, 2, 3 surgeries are always there for Dr. Bhavesh. And come have a look at what type of precautions are taken. I'm sure that we can all play an important role in taking care of obese patients in the best possible manner. More importantly, in those setups where obesity and bariatric surgery is not treated regularly, you all could bring about a lot of change in the mindsets of those particular consultants regarding the best methods to treat an obese patient inside the feel this is what I wanted to just convey. I'm so happy that such a important topic has been taken over by the Anesthesia Society. So thankful that you all had me over here with you all. It was a pleasure interacting with you. If there is any question that you would like to ask or I can answer, I'll be more than happy. Otherwise, I would like to be a part of the event as it goes on.
That was wonderful, sir. Thanks for the invitation to your center. We would definitely visit with Bhavesh, and it was really wonderful talk. I think we can continue now, Bhavesh.
Yeah, so I will just start sharing the slide and we continue.
Yeah. So now our next topic will be pre-operative evaluation and optimization of obese patient. And Dr. Bhavesh Nanda is going to present his talk. Dr. Bhavesh done his MD from Tata Memorial Hospital. He is Chief Anesthesia Consultant at Astha Bariatric Center. He is director of Padma Shri Maternity and Nursing Home. He is vice president of Thane ISA. He is member of Indian Society of Critical Care Medicine. He has special interest in bariatric surgery, difficult airway, and critical care. Friends, Bhavesh is going to give us very practical tips about the preoperative assessment when we encounter obese patient. Over to you, Bhavesh.
Am I audible very well?
Yes, yes.
Good evening, everybody. Thanks, Dr. Manish Motwani, for a very lovely and short lecture. We have done a multiple number of cases, as Dr. Manish Motwani said, and we have found the innumerable cases of patients having a lot of comorbidities, and they have had a tremendous improvement in their lifestyles. You can come and visit at Asta Bariatric Center of Excellence. Anytime you can give call. We are always available. We start at 7:30, and everybody's invited. So with this note, we will start our next session. First of all, I would like to thank ISA Thane branch President Dr. Meenal, its members, organizing secretary, co-speakers, chairman Dr. Manish Motwani, moderator, my colleagues, mentors, teachers in the audience to give me opportunity to share this scientific session. As Dr. Manish Motwani sir told, obesity is a global phenomena, slowly growing pandemic, I would call, if sheer numbers are taken into the account. Medical profession, especially anesthesiologists here, and will be having a very major responsibility and challenges to deal with the diseases, as they will be coming for procedures, minor, major, supra-major, pain, trauma, critical care, and many more. So, according to the Obesity Medicine Association, the definition of obesity is a chronic relapsing multifactorial neurobehavioral disease where there is an increase in body fat, which promotes wide adipose tissue dysfunction and giving rise to metabolic, biochemical, biomechanical, and psychological health consequences. As we know, prior to going to detail about pre-operative evaluation, we would just, in short, we will come to know about why this obesity gives a challenge to all and why all organs are involved. As you see from this slide, that the major problem is the deposition of or the increased secretion of white adipose tissue, which gives rise to excessive secretion of adipokines that are inflammatory markers such as free fatty acid, tumor necrosis factors, IL-6, IL-1, necrotizing factors. And if you see according to all these slides, what it gives is that at each level of metabolism, a pre-metabolic level, there is a problem. As you see, there is a lipotoxicity which gives rise to insulin resistance. There is a dysfunction in the islet cell which gives rise to reduced glucose transport, hyperglycemia, hyperinsulinemia. There is an increased lipolysis and sympathetic nervous system stimulation. Also interferes with the triglyceride metabolism, which gives rise to dyslipidemia. It also affects the renin-angiotensin mechanism and indirectly gives a problem to endothelial dysfunction, which gives rise to hypertension and acute kidney diseases. The acute phase reactions, as we know, are very procoagulant, and these patients are more prone to develop thrombotic phenomena, especially also because of the macrophage infiltrations and dysfunctions. They are immunologically very poor people prone to develop an infection. So the topic, what we are going to discuss in the session is in such way, we are going to first discuss about the history, the BMI, define the obesity by BMI, airway assessment, respiratory assessment, metabolic syndromes, cardiovascular, other systems like liver, obesity in parturients, a small talk about it, neuropsychiatric problems, sarcopenic obesity. These people also have a substance abuse, a general checkup, and at least some thing regarding types of bariatric surgery, and then we will summarize. We will take question answer sessions in the end. So the history taking actually takes the major part of our pre-op evaluation. It starts as soon as the patient enters the PAC room. So once the patient enters the PAC room, we can see obese patient accompanied by probably an obese mother or a father or a sister or a wife. And the way he walks inside, we can come to know. By seeing him, we can come to know whether he is a central obese patient or a pear-shaped or a peripheral obese patient. We need to see how he is moving around, whether he has got any disabilities, walking disabilities. There is a problem in the knee. It is a very important thing to know that how he is walking. We should see about his mood and depression, because most of these patients are basically perennially depressed and very difficult to convince them and talk with them. So the moment that they enter and make them comfortable, feel that they are a part of general population, we should give them a dignity feel while communicating with them. During the history taking, we need to also ask about the process of weight gain. Now, these patients, basically, it is a so slow weight gain. He was whether obese from the childhood, whether he was obese after surgery, or a lot of patients who take some antipsychotic medicines, they do gain weight. So it is very important to know the process of weight gain, whether they have had any attempt to lose the weight. That gives us the motivation to lose the weight. So these people who are actually motivated, they are generally they do very well during perioperative period. Ask about the eating habits, whether they eat more of fried food items, they keep on eating something called as anxiety, neurosis. These people also have a bulimia. So all these things we can come to know through the patient's history taking. Ask for a system specific organ involvement, such as hypertension, cardiovascular, such as hypertension, whether he is dyspnea, whether he is able to perform meds less than 2, like climbing stairs, whether he is able to walk straight more than about 1 kilometer and all, whether he can go to toilet without any support, whether he can fold his legs. So these are all very important things and all. And as usual, it's a normal pre-ovulation. We need to ask about what type of drugs they are taking for treating the conditions such as psychiatric, diabetes, hypertension, asthma. Another important aspect is that these patients, because of the mood problem and all, they are mainly into substance abuse, something like smoking, tobacco eating, alcohol, many other drugs. And we need to know and ask about how long they've been using it. So it's very important that we advise them in the pre-operative workup that they need to abstain from this thing. Any previous history of anesthesia is very important for us, because these patients are more prone for awareness, how they were maintained, whether they were pain-free during the procedure or post-procedures. If they were unaware or they had a very good post-operative outcome, then they are very much likely that for next surgeries or bariatric surgeries and all, they will be accessible to us. See for the mobilities and disability. And in recent trends, as you have seen, that the obese in COVID has been in general population has been very more. They are more prone for developing the complications. So ask for a history of COVID, whether they had a COVID. If yes, then whether they were given hospitalized. If yes, oxygen was given. If yes, then whether he was in ICU, required any non-invasive ventilation. All these things are very important, because certain type of investigations and the organ damage will be more associated with these people, and they will complicate our pre-op evaluation. So the next way to define obesity is by various methods. One thing, the most commonest is body mass index. Others are like fat ratio more than 25% in male and 32% in female. We call them as obese. As you know, 7% of the world population are obese, and we will be shocked to know that prevalence in India, that is a 2020 report, is 40.3% of the people are obese. Age is a very independent risk factor in obesity. That is, age above 65 is an independent risk. Now, the classification of BMI, the BMI is calculated by taking the weight in kilogram and dividing it by square meters. So as you can see from this graph, the patient less than 18.5 is underweight. The obese category falls above 30, that is moderate. Class 2 is around till the 40, more than 40 is very severe. Then there are multiple classifications. More than 40 to 49 is super obese. 49 to 50 is super obese. More than 60 is very super obese. But for us, we should know that the obese patient itself is a challenge. And the obesity above moderate level is a specific challenge for an anesthesiologist. Another way to find out is by waist circumference, especially in Asian population, waist circumference more than 80 in women, and in men more than 94 centimeter. In Caucasians, it is more than 88 and 102 centimeter respectively. As we discussed, there is a fat distribution throughout the body, and the major part of the organ involvement or problematic part in the obese patient is basically because of fat distribution. Now, there are something called as apple-shaped obesity and pear-shaped obesity. Apple-shaped obesity is a central or a visceral obesity pattern, and pear-shaped is a peripheral adipose tissue fat. The most important critical part is central obesity. That is a major contributor for metabolic syndrome and its complication. And as we discussed in the previous slide, that obesity itself is a chronic inflammatory state, and all the problems related to obese in the organs is secondary to the chronic inflammation. We'll come to an airway assessment. There are the airway challenge to the anesthesiologist is one of the most fearful things what we actually as an anesthetist we fear about it in any case, and obese definitely pose a more challenge. As we can see, 30% there is an increased 30% chance of difficult airway in an obese patient. So what are the major parameters to look for? There are many multiple indexes, scores to know the difficult airway, but here we are dealing with an obese difficult airway, not a normal difficult airway. So the most important parameters what we need to know is which are going to affect directly for the intubation or a difficult intubation is neck circumference. We need to measure for each and every patient, which if it is more than 40 to 42 centimeters, it poses a big challenge. MPC grade more than 3 is a big challenge, and combination of about thing, according to the research, is a major predictor for difficult intubation. We need to also see for the movement of the neck, that is flexion and extension. The movement of the neck is important because most of the patients have a pad of fat behind the neck and very difficult to even keep the pillows or to arrange a ramp position, and also for extension of the neck. Another big predictor is a TM distance, that is thyromental distance, is another predictor for difficult airway. If it is less than 6 to 7 centimeters itself is a challenging thing. A new ratio has come that is called as neck circumference to thyromental distance, and which is more, if it is more equal to or more than 5, then it is definitely a predictor for difficult intubation. I would say difficult airway. The reason is that these people are also having a challenges of holding the mask because of having endocrine something like macroglossia, a big jaw. It is very difficult to ventilate post-induction, and they have a fat at retropalatal space, parapharyngeal space. They have a long epiglottis and tonsillar. Most of these patients have got a tonsillar enlargement. I keep on seeing a lot of tonsillar enlargement, and it becomes very difficult, especially when we do a video laryngoscopy and we keep on focusing on the scope rather than on putting the tube through the mouth, and then we can go in the tonsillar space and damage the tonsillar pillars or enlarged tonsils and give rise to tremendous bleeding. Wilson score more than 6 also is a potential thing, but it's not as sensitive as in obese patient. As we know, Wilson scores take 6 parameters into account, like weight, jaw, movement, mandible, head neck position, rotation, buck teeth. Though I am not going to go detail into this scoring system, as this is not a sensitive method in airway assessment for an obese patient. After airway assessment, we will go for a respiratory system assessment that we will divide into a chest or a lung. And another big major contributor for mortality and morbidity is obesity, obstructive sleep apnea syndrome, and obstructive hypoventilation syndrome. So what is the problem in this respiratory system? Because of fat deposition in the chest and the chest wall and the thoracic cavity, these people have a reduced chest wall and lung compliance. And simultaneously, because of increased fat mass and increased body structure, they have increased work of breathing and increased oxygen consumption. So the most commonest findings what we see in a pulmonary function test is they are having a reduced vital capacity, expiratory reserve volume, and a functional reserve capacity. If we see the PFTs, there will be a functional vital capacity in FEV1 is mildly reduced in a mild obesity, but the moment the obesity grade increases, they keep on reducing. If we calculate the ratio, then in general population, it will be a mildly normal in mild cases, but increase in severe obesity. The problem of having a low FRC is when the FRC approaches closing capacity, there is a problem of desaturation and hypoxemia in these patients. Already these patients have a VQ mismatch. They have a left to right shunt and arterial hypoxemia. Hence the safe apnea period time during our procedure is reduced. And desaturation is very common during induction of anesthesia after giving propofol or IV induction or gas induction. The normal safe apnea time is about 8 to 10 minutes, but in these patients, it's hardly 2 to 3 minutes. So the role of pre-oxygenation is very important in this type of patients with patient positioning or use of certain PEEP methods during the induction time. Normally, we find a restrictive type of pattern in this obese patient. But sometimes because of comorbidities or smoker and all, they may have a mixed type of restrictive as well as mild obstructive physiology. Most of the things, asthma is a very common condition in obese patient, though very difficult to diagnose because the symptoms overlaps each other. But one of the peculiar finding of asthma in obese patient is that they don't respond to beta agonists, something like salbutamol or esthalin. I mean, that's a salbutamol and also they don't respond. The main reason is the fat deposition in the alveolar space and interalveolar spaces because of chronic inflammatory state, and hence they don't have any recoil value. Optimization of these patients are most important is for the weight reduction. It will be either by nutrition or by weight loss surgeries. We need to increase his respiratory as well as expiratory muscles by doing a pulmonary rehabilitation. Now, there are certain exercises like that is called as pursed lip breathing or a diaphragmatic breathing exercise. Now, that can be easily taught to these people on pre-operatively. What we need to do is that the patient needs to inspire through the nose, and while expiring, he has to purse through the lip and purse as long as he can expire out. Same thing is with the diaphragmatic breathing. Says he has to hold the breath, put a pressure on abdominal muscles, and then expire. Incentive spirometry, normally for bariatric patients, we keep on doing, but nowadays in a recent researches, they say it is a debatable thing, but the recommendations are strong, but the evidences are weak. Inhaler tools are in a gray zone as routine, but immediately pre-operatively does help to clear the mild bronchospasms in this type of patient. The role of CPAP or a positive airway pressures will be discussed later. The breath holding test is also a good parameter, but it's very difficult to judge in this patient because we hardly see the chest movement. So we need to have to keep the hand over it and may not always be correct. The investigation of choice to know the dysfunction about this respiratory system and airway is we should need to do an ABG, which will show a high PCO2, a PFT as described later, what we need to see in the PFT, and HRCT indications as and when required. But nowadays in a COVID situations where the patients who were ventilated, they do have a lung damage, and it is very prerogative that we do an HRCT on those type of limited patients, not for all patients, so that we can come to know they have sometimes bullas, they have cavities, they have collapsed lungs, the trachea may be on the sides, and that may definitely be a very risk factors during perioperative period. The major part of OSA or obesity hypoventilation syndrome will be talked later by Dr. Alpa Madam. But as a pre-op evaluation, this is one of the major factor to know. As we take in history about the snoring history and all, we should come to know, we can ask them about snoring, the tiredness. So they have come up. So as you see, 50% of the obese patients have OSA, and significantly many of them have an obesity hypoventilation syndrome. If both together, then it is a very challenging thing for anesthesiologist as well as post-operatively for this patient to maintain good oxygenation or pulmonary complication. There are multiple questionnaires or scoring systems have come, some such as a stop bang or a Berlin questionnaire, but most commonest followed is stop bang. The stop bang is divided into a two-part. So basically, there are four questions to be asked in that and four parameters to be noted. Each has got a yes or no. Each is given a point of 1. So scoring is given for 1 or 0. So what are the stop bang? The stop bang says that S stands for snore. Now snore means whether the patient is snoring loudly. So loudly means what? Nowadays, if you see obese patient, even normal non-obese patient do snore, but the snoring is like the level of talking or loud enough to be heard through closed door. Then that we have to score like a yes or no. The patient feel tired. So normally this patient don't have a good sleep throughout the night. So they feel in the morning, they feel somnolence in the morning, they feel fatigued, they feel tired. So that is also a big factor affecting the perioperative morbidity and mortality. Has anyone observed? So you can ask your co-partner, your mother, father, and all whether there is a stoppage of breathing. So whenever they snore, normally the next person gets awake and he sees. So sometimes they make them wake awake because he's struggling to breathe, and that's a very poor indicator for post-operative complications. Then whether these patients have a high blood pressure. In the bang, the B stands for BMI, which is more than 35, the age over 50, and neck circumference more than 40 to 40 centimeter, and gender male. The gender male is a question mark in this. But what is more important is score above 3. We need to ask for a sleep study, and score above 5 definitely indicate some form of intervention prior to surgery if we got a time other than non-elective surgeries. It is a major predictor for post-operative complications. So what do we need to see in a sleep study? So I'm not going to go into detail, but I will be just talking about some factors what we need to see. So what we call is an apneic-hypopneic index. So what defines an AHI? So AHI means apnea-hypopneic occurring more than 5 times or lasting for more than 10 seconds is this one. So if it is more than 5 to 14 times, we grade as a mild, moderate more than 15 to 30 times AHI, and severe more than 30. The more the grade, the worse the complications and more the chances to preoperatively treat them with some form of BiPAP therapy or CPAP therapy or some form of maxillofacial surgeries and all these dental people keep on doing nowadays. The obesity hypoventilation syndrome, I will just talk in something like what is the criteria. The criteria are we do an ABG, find the arterial CO2 more than 45, that is hypercapnia, a rate bicarb more than 22, and hypoxia is a triad of OHS. Now, how to optimize these patients? So send to a sleep specialist. They will do a polygraph somnography test, and then they will find out a total sleep study they will do, and then they will titrate that person to CPAP or BiPAP. And normally it is advised to have a 4 weeks CPAP or a BiPAP prior to surgery, but not most of the patients are not compliant. They are not comfortable. So any amount of CPAP pre-op is necessary for them. So what they do, they actually improve the pharyngeal space, improve the hypertension, improves the FRC, and hence during perioperative period or during the induction, they do help us for intubation. They make our life easy to increase the safe apnea period. Now, what they have found is that 10% of the weight reduction improves OSA by more than 26%. So we can imagine this patient, how they will get better by weight reduction, either by medical, diet, or mainly by bariatric surgeries. What we need to do is we need to do an ABG and a polysomnography test. The major dreaded complications in obese patient is a metabolic syndrome. So it is a cluster of condition, mainly contributor for a perioperative morbidity and mortality. As you see, it includes central obesity, hypertension, diabetes, impaired glucose tolerance, dyslipidemia, and reduced HDL. Now, what is how to diagnose it? So if you see from this slide, the highest circumference, as I told, 88 centimeter in women and 102 in men. Plasma glucose level more than 100 milligram per deciliter, or are diagnosed with type 2 diabetes mellitus, triglyceridemia, which is more than 150, a low HDL, which is less than 50 in women and less than 40 in men, and a higher blood pressure, 130 systolic and 85 diastolic, or a diagnosed hypertension. As you see from this slide, this metabolic syndrome, it generally affects each and every part from head to toe. And if you see these patients, if they are not treated properly, they have a loss of grave volume matter, which gives rise to Alzheimer's, vascular dementia, stroke. In a ladies, they are known to give rise to polycystic ovarian disease and hypothyroidism, hyperthyroidism, and infertility. The patients do develop non-alcoholic fatty liver disease. Invariably, if not treated, will give rise to NASH and then probably a cirrhotic liver at a later stage, which will be directly contributor to the preventable cause of deaths. And the diabetes, as we see, they develop a diabetic retinopathy, renal hypertension. Now, if you see from the previous slide, the 40% of the people over 60-year-old have a metabolic syndrome, and even a reduction of weight by 5% will reduce the risk of metabolic syndrome by about 20-30%. 85% of the people, as Dr. Manish Motoni said, have a diabetes in this obese patient. So what is the optimization? So optimization is purely a bariatric surgery for this type of patients, but because all these patients may need not come for bariatric surgery, majority of them come will for non-bariatric surgery. So during pre-operative evaluation, we need to refer them to a dietitian or a nutritionist. So a small weight loss by 6 to 10%, that is by restricted calories, about 800 to 1000 calories per day with a high protein diet, is known to reduce the liver size as well as reduce good control of diabetes, hypertension, triglyceridemia. What is more important is that these people are also nutritionally depleted of substances, so we need to replace them with vitamin B12, vitamin C, micronutrient, and vitamin D. These all vitamin B12, vitamin D are direct related to cardiac as well as liver as well as a bone metabolism and perioperative risk. we need to note down the drugs to treat diabetes mellitus, hypertension, dyslipidemia, because they are going to be very important modification we need to do during pre-operative or a perioperative state. There are certain drugs where the bariatric surgeons and dietitians will start for the loss of fat in the body. That is about 3 months prior to the surgery. That is orlistat, which is a FDA approved, which is given as 60 milligram 3 times a day. And there is another FDA drugs. There are multiple, but the commonest is another is phentermine, which is a centrally acting. So that can be given in a patient who is having a bariatric. So we can give it orlistatin with in a patients who are having mood disorders or bulimia nervosa, all those patients. So what are the level for glycemic control? So now non-bariatric patients, 8.5 is a target. More than 8.5, they are known to have sepsis, pulmonary complications, cardiac complications, and wound infection. But in bariatric surgery, earlier there was a thought about coming to 8.5, but we know that metabolic syndrome itself is a disease, and unless you treat the weight loss surgery, these things are not improved. So nowadays there is no cutoff point for HbA1c in a bariatric surgery. Exercise is one of the major things, that is pulmonary rehabilitation. So they can go for an aerobic exercise, which are mild and moderate, lung exercise. Refer to endocrinologist because they need to be a part of a team. But the most important is weight loss surgery. So investigation regarding metabolic syndrome, what we need to ask is specific according to the system. So complete blood count, complete liver profile, renal profile, electrolytes, coag profile such as PT, INR, a thyroid function test, because these patients do have hypothyroidism, many of them, especially males also. A blood group and a urine test are a common factor among those. Next on, we move on to cardiovascular system. Another commonest system involved in obese patient is a cardiovascular system. So the cause of involvement of is because of increased body mass and a poor lung compliance. So they have normally a right heart failure. So it is because of secondary to pulmonary hypertension. These people are having a polycythemia that itself contributes to right heart overload. These people have an OSA, so they also have a right heart pulmonary hypertension. The most commonest findings what we find in cardiovascular systems are these patients are hypertensive. We need to see for signs of left ventricular hypertrophy, left ventricular failure. These people are very prone for cardiac arrhythmias because there is a fat deposition in the myocardial or myocytes as well as in the conduction system. So you will have a lot of arrhythmias from a block till supraventricular or a ventricular or an arrhythmia, atrial tachycardias. These people are known to develop cardiomyopathy. Now, during examination, we need to look for the signs of heart failures, such as in history, dyspnea of exertion. We need to see for the raised systolic blood pressure. We need to ask for the reduced METs less than 4 and less than 2 is definitely a perioperative risk. We need to see for the jugular vein pulsation, which is very difficult, but we can see very well. Pedal edema, not so, because most of the patients have a pedal edema. Very difficult to know whether it is because of heart failure. S3 sound or a gallop on rhythm, very difficult because they have a very high chest wall. So it is very difficult to hear the heart sound. Investigation of choice are a 12-lead ECG, an echocardiography, stress test. It can be Dobut or a physical stress like a treadmill, but treadmill is very difficult because these people, they hardly are able to walk. They cannot run. They have a comorbid back pain. They have a knee pain, and also better to do a Dobut stress test. To rule out the end organ like a failure and all, we need to do a pro-BNP to know whether they are having an acute heart failure or a chronic heart failure. A newer modality of treatments have non-invasive methods have come, what we call is a SUMO, that is a stress sonography in morbid obesity. So combined with a stress test. So what it does is that we inject some ultrasound contrast in the patient's vein and it creates a good contrast. So a normal echocardiography, we don't get a good window to see the myocardium, and this definitely helps. So this actually is very helpful in the patients who have got preoperatively heart failure or an IHT, and we cannot diagnose through 2D echo, and we don't want to put them for a coronary artery coronary angiogram. So this test will definitely help who are going to require a revascularization. There are other tests like MRI, nuclear medicine, just to complete the investigations. What we need to see in 2D echo is look for an ejection fraction, a diastolic dysfunction, radial wall motional ability, and pulmonary pressures, which are normally raised. If the pressures are very raised, then we need to treat it by giving a CPAP, by weight loss, or by some medications, like a calcium channel blocker or other drugs. CAG, unless indicated, it is not advised. DVTs are very common in obese patients, so prior Doppler and history in prior episodes, we need to be very careful. We need to come with a revised cardiac index in this type of people. Everybody knows about it, like from class 1 to class 4, the mortality is like 0.4, 0.9, 6.6, and 11.1%, depending upon the grade of cardiac risks. The optimization is surely a weight loss pre-op, the drugs to control the heart failure and arrhythmias. What we see is a lot of patients are referred for cardiopulmonary exercise testing. So what does it do? It actually identifies 3 parts. First is that it will tell us whether the patient is having less efferent secondary to pulmonary cause, cardiac cause, or a skeletal muscle dysfunction. So individually we can target that, and we can make the patient pre-optimized for prepare for surgery. Cardiologist reference is a must. Most of these patients are on antiplatelets, and we need to stop for that. Everybody knows the perioperative anticoagulant protocols, but in short, most of the patients are on dual antiplatelets. So for them, compulsory 7 days prior stoppage is necessary. Bridging according to the indication, according to primary cause or secondary cause. Ecosprin, we need to stop for 5 days according to type of surgeries, like minor, major, intermediate, and this one. But for non-bariatric surgeries and all, then we can continue till then if it is a minor surgeries or intermediate surgeries. Clopidogrel, definitely 7 days of stoppage. This patient, because they are prone for deep vein thrombosis, thromboprophylaxis is very must. 24 hours prior to the admission, normally weight more than 100 kg, we give 0.6 ml subcut, and weight less than 100 kg, we give 0.4 ml subcut as a prophylactic dosage. Other organs and systems, main is liver. The liver complications because of fat deposition can give rise to non-alcoholic fatty liver disease and non-alcoholic steatotic hepatitis, which is a deadlier form of NAFLD. These patients are prone for liver cirrhosis and liver diseases and hepatocellular disease. So what we need to see is that whether they are having a deranged liver enzyme. So normally most of this bariatric or an obese patient, no doubt, they have raised liver enzymes, but they are not much. They are less than 100. But if they are generally very high, then it definitely needs to warrant and come find out the cause of it, because they definitely perioperative hepatic dysfunctions is very common in them. So it interferes in our drug metabolism and clearance. We need to titrate the dose according to weight. We need to avoid the hepatotoxic drugs. Optimization is by liver shrinking diet, as I mentioned. So what the studies have found, 7 to 10% weight loss prior to surgery reduces the size of liver by 14%. And in general, it helps during the bariatric procedures, basically, to retract the liver and do a surgery at a cardioesophageal junction. What we need to see is that we need to do a liver function test. Occasionally, sonoelastography can be done if we are having on sonography a part of a liver cirrhosis or a liver biopsy to diagnose it. Most of these patients are posted for ogidoscopy because these patients do have hiatus hernia. They have reflexes. Most of the patients have varices. And H. pylori infection is one of the major comorbidity in that. If they are having, then this is a very high cause of sepsis perioperatively to the patient. Preoperative acid reflux prophylaxis is a must. In short, something about most of the patients nowadays we see a pregnant lady comes with obesity. So the definition of obesity is slightly different in obese patient. Like where we see less than 8.5, we have calculated 24, 25, 29. So what they have come with the weight gain during the pregnancy. So for mild to moderate, the weight gain around more than 11 kg or 12 kg falls under category of obese, and above it, more than that, will fall under severe obesity. Now, as we know that the obese patients are more prone for gestational diabetes, hypertension and disorders, and venous thromboembolism, and it poses a major challenge to an anesthesiologist. They are having an increased chance of cesarean sections. They have a prolonged first stage of labor and increase in mortality. Most of these obese, they are having more chances, like 24% chance to have an OSA than in non-obese patients. So actually, it compounds our induction if we want to give a general anesthesia for this type of patients. There are more chances of failure of neuroaxial procedure in this patient. So the OBY, that is a gynecologist, should diagnose the patient as a obese patient, refer to anesthesiologist, better in second or third trimester. In the third trimester, if a patient is found to have obese, and then need to do a sleep study and something which is called as a peripheral arterial tonometry. So that is another method to Diagnose an OSA in the patient who are having an obese patient. Discuss in pre-op evaluation, discuss the patient with the patient about labor analgesia. During the admission, do elective placement of catheters rather than in emergency. For the sole reason of we don't want to give general anesthesia for this type of patients, and we don't want failure for neuroaxial things. Thromboprophylaxis in this type of patients, like BMI more than 30, age more than 35, and parity more than 3, definitely we need to give them a thromboprophylaxis. Another one major factor of this obese patient are they are mainly are having a mood disorders. So what is called as a major depressive disorder or a metabolic mood disorders. Now these patients, if you see, majorly fall under cyclothymia component. They have emotional dysregulations, executive when you're doing a fine motor task. They have an impulsive addictive behavior. So they normally have a mood disorders and attentive disorders, hyperactive disorders, invariably giving rise to more eating disorder, obesity, and a whole circle keeps on going. So most of these patients are mainly on anti-psychotic drugs, and we need to note down because there are certain drugs which are known to interfere in our perioperative care. A small passing down about sarcopenic obesity. That is nothing but an obesity where the person looks obese, but you can see the skin hanging down. There are wrinkles and basically loss of muscle mass. The criteria are poor grip strength, history of immobility, they have a slow gait, very common in old age. The prehabilitation is the only way to treat it. As we see, normally we have been doing bariatric in an older age group, but normally bariatric surgeons or general surgeons, they will try to avoid doing bariatric surgeries in the age group more than 70, 75 age group for the sole reason of having a multiple increased cardiopulmonary risk as well as mortality in this type of people. On history, the smoking. So there are preoperatively smoking, cessation of smoking if 3 months prior, but that's most of the time not possible. Even 10 days prior to the surgery reduces the post-op complication risk. Alcohol abstinence more than 2 weeks to 4 weeks helps. Need to stop the tobacco. Substance abuse is very common in this type of people. We need to. So in general physical exertion, we also need to look for an IV access. Note down where are the good IVs. A right size of BP cuff is very necessary to measure the BP. Nowadays, we get a conical shape BP cuff. Do have the proper discs are there. Look for the spine because most of these patients who are not going for non-bariatric surgeries are going for a regional anesthesia or a pain control, especially pregnancy and ortho surgeries. USG localization of the site for epidural spinal procedure will definitely increase our chances of success. Arterial only if is required. Look for the cuff for DVT and other signs of reduced perfusion. See for the pressure points, see for neurological deficit. But also another important part is to learn about total body weight, lean body weight, and ideal body weight for drug dosing, which will be talked later during the perioperative care of the patient. This is all for our pre-operative assessment, but something I would like to talk about the type of bariatric surgeries. There are multiple type of bariatric surgeries such as vertical band gastroplasty, a laparoscopic adjustable gastric band. The commonest is vertical sleeve gastrectomy. There are multiple jejunal bypass, biliopancreatic division, or biliopancreatic division with duodenal siege, and Roux-en-Y, that is called as gastric bypass, and something called as mini gastric bypass and a gastric balloon. So these all surgeries are indicated for certain type of people. So it's a bariatric surgeon who is going to decide which is best for that person. And the perioperative mortality or post-operative surgical mortalities, there is something called as obesity surgery mortality risk, which surgical society has found out. The BMI more than 50, a male gender, a hypertension, a previous history of pulmonary embolism or a hypoventilation or an OSA, age more than 45 falls under category of this. The scores are given from 0 to 1, 2 to 3, 4 to 5, ABC, low risk, high risk. As you see, as the risk increases, the mortality post-operatively directly related to this part is very significantly high. So to summarize the thing, obesity itself is a separate disease. We need to take a proper history, define a BMI. Risk stratification is very important. ASA. Now ASA categories, there are a lot of articles where how to grade ASAs. But in general, BMI more than 30 is ASA 2, BMI more than 40 ASA 3. So the risks varies from 0.8% to 15% of the perioperative or post-operative mortality. Revised cardiac index risk system, stop bang, airway score, which we need to put on a paper. assessment of airway, respiratory system, diagnose OSA, diagnose cardiovascular risk, metabolic syndrome, treat the patient for his neuropsychiatric symptoms, optimize this patient if he get a time other than non-emergent situations. Nutrition pre-op plays a very good role. Ask for a relative indication to quantify the risk for surgery, calculate the total body weight according to thromboplastic is a must. Keep ready DVT pump, USG for central venous or spine localization. Drugs for comorbidity should be returned. Specialist opinion and communication between the different specialties is a very must. ERAS recommend non-obese fasting protocol. Evidence is big, but recommendation is very high. So we would prefer to have an overnight fasting, like 8 hours fasting. And with this, I conclude my talk. Thank you very much.
Thank you so much, Dr. Bhavesh. It was absolutely comprehensive talk about preoperative evaluation and optimization. There was only one question in chat box about psychiatric evaluation, but I think you have already spoken about it.
Yeah.
And I want to ask one question. You said that these patients are not very responsive to beta agonists.
Pardon?
So,
I didn't get it.
They don't respond to beta agonists.
Yeah.
So
yeah.
Which are the other drugs we should keep ready?
So better to give with steroid drugs, something like a Foracort or Budocort and all. So at least that will reduce the inflammation of the alveolar system. So that will definitely help. But as I mentioned, preoperatively it is very important because normally these patients, they have a reflex disease and they have a reactive airway. So at least acutely they will help it.
So during acute phase, we can use adrenaline.
Yeah, we need to give them.
Okay, fine. Thank you so much, Bhavesh. Dr. Motwani is there. Who wants to put any comments? Or he's left. Dr. Motwani is there. Motwani sir is there. Otherwise, we can.
Dr. Manish.
Next session. Okay, we'll I think proceed to the next session. Our next speaker is Dr. Alpa Dalal Madam. We know that obesity many times associated with OSA, and when we come to know that our patient has got OSA, it is very alarming, as the intraoperative and post-operative course of the patient can be turbulent. So to guide us about this OSA, today we have called Dr. Alpa Dalal Madam. Dr. Alpa Dalal Madam is HOD of Pulmonology in Jupiter Hospital. She is nodal chairman at Savory TB Hospital. She is practicing in Thane and Mumbai since 27 years. Madam has done MD chest from KM Hospital. She has 15 publications in national and international journals. She has special interest in MDR TB, sleep medicine, asthma, and pulmonary rehabilitation. I would like to talk about her work on yoga. She has published paper on effect of Kriya Yoga on neurocardiac physiology. And in collaboration with Chest Research Foundation, she has conducted research on impact of breathing exercises, meditation, and sound therapy in COPD patients. And she presented this paper in 2019 in Barcelona. So we are very, it is a privilege for Thane ISA to have you, madam, and very warm welcome to you. You can proceed with your session.
Thank you so much for that kind introduction, and let me thank you, the ISA team, Dr. Sonali, Dr. Manisha, for inviting me to talk to you on this subject, which I am very passionate about. And so I think nowadays, with the awareness of OSA increasing and with obesity pandemic, we are seeing more and more patients being referred for sleep evaluation, and perioperative management of OSA patient is actually becomes a key to improving their outcomes in our obese patients with not only bariatric surgery but other surgeries and procedures as well. So with this, I would like to start my presentation. I'll just share my screen. Just a minute. Can you see the presentation?
Yes, madam, we can see.
Can see. So let's start with the topic. Excellent presentation by Dr. Motwani and Dr. Bhavesh, and you got a fair idea about various perioperative issues that an obese patient is going to face. Today I'm going to specifically focus on obstructive sleep apnea, and it's a vast topic actually, but I'll be focusing more on perioperative issues of OSA patients. So the outline of my talk, that what's the role of anesthetist in OSA patients? So how do anesthetists assess the OSA patient? So you must know what is the incidence and epidemiology. So how often are you likely to find OSA patients in your practice, in your pre-op evaluation? Then how do you diagnose? Not all patients will have a sleep study, or not all patients would have access to sleep study. But there are some clinical evaluation points, some scales which you can use. Dr. Bhavesh already discussed about one of this commonly used scale. And actually the gold standard of diagnosis is sleep study. Then you have to assess the risk of the patient. So what is the severity of OSA? What is the age of the patient? And all these obese patients are definitely going to have multiple comorbidities associated. So that also becomes part of your risk assessment. Then the next question is, what is the type of surgery? The risk would be much lesser if it's a peripheral surgery, and would be much higher if it's abdominal or thoracic surgery or airway related surgery. What is the type of anesthesia that is required? And another point would be that newly diagnosed patients, then how would you treat that? So first time when the patient came to you for pre-op evaluation and you diagnose this patient clinically, or patient has pre-existing OSA, and if the patient has pre-existing OSA, whether he is being treated or is not being treated. And then the most important question is, can we postpone the surgery? And this is, I think, a common point where surgeons and anesthesiologists and the physician may not agree, and that becomes a real challenge. How urgent is the surgery? Do we have time to optimize the patient? Do we is possible to postpone the surgery to optimize the patient? And lastly, we'll be discussing what different protocols to be followed, pre-op, intra-op, as well as post-op. So this is the outline of my talk, and just let's start. So first, coming to the definition of obstructive sleep apnea. So obstructive sleep apnea is a syndrome which is characterized by periodic, partial or complete obstruction of the upper airway during sleep. So this leads to repetitive arousal from sleep, and which by turn results in daytime hypersomnolence in adults and aggressive behavior, lack of focus in children. You may be getting many pediatric patients also with OSA, because the incidence of obesity is increasing in pediatric population as well. And many of these pediatric patients have actually non-obese form of OSA also, because of enlarged tonsils or adenoids. So this OSA leads to increased incidences of perioperative hypoxia, hypercarbia, especially if the patient also has associated obesity hypoventilation syndrome, cardiovascular morbidity, and mortality. So why should you know about OSA? Because obstructive sleep apnea is a major individual as well as public health problem. In India, the prevalence of obstructive sleep apnea syndrome is 2.4 to 4.96% in men and 1 to 2% in women. So this is older data. I suppose now the latest data, this incidence would have definitely increased. Especially during the pandemic, we have seen that the incidence of inactivity as well as obesity has gone quite up, and this incidence must be much more, I feel. In the rest of the world, the prevalence is about 4% in men and 2% in women. And the important part is that 93% of women and 82% of the men with moderate to severe OSS are never diagnosed. And many of your patients whom you will evaluate preoperatively, you will realize that these patients have never been diagnosed with OSA. Okay, so what are the different complications we are talking about? So perioperative complication is a big list. You can divide them into cardiovascular complication, complication related to airway obstruction, unmasking of overt or mild OSA. Many times we are surprised on table, like in sometime in procedure like endoscopy, that patient may not be having obvious symptoms of OSA, but the moment you give them sedation, even mild sedation, it can precipitate. Mild OSA or overt OSA can get precipitated, or moderate OSA can become severe. And then there are other complications. So cardiovascular complications are very common, and number of studies have shown, randomized control studies have also shown that patients having OSA have much higher incidence of these various complications. So myocardial infarction, am I audible and visible?
You cannot see the screen, madam.
Yeah.
Screen sharing has stopped.
Screen sharing has stopped.
Yeah.
Okay. Let me see again.
Okay.
Can you see now?
Yeah. We can see. Yeah.
Okay, right.
You're audible also. No problem.
Yeah, what exactly happens in OSA? So normally during sleep, the muscles which control the tongue and the soft palate, they hold the airway open. So this is a airway of a normal person. So normally the muscle tone is good enough when the person sleeps to maintain the patency of the airway. A patient who has gentle snoring, these muscles relax too much, so they have hypotonia of this muscle, and that results in narrowing of the airway, and this causing snoring, sometimes breathing difficulties. But this patient still doesn't have OSA. But what happens in OSA patient, that this patient's muscles relax too much, the airway can sometimes becomes completely blocked, preventing breathing, and this leads to episode of apnea or hypopnea. So you can see here this is a MRI image, and you can very well see what are the levels where obstruction can happen. The commonest regions are retropalatal and retroglossal. So you can see the tongue, the size of the soft palate, and the mandible, whether it is retroverted, whether it is normal position. Then the subcutaneous fat. So you can see here, person who is obese has subcutaneous fat, has parapharyngeal fat. And these patients, if there is a large tongue, there is fat deposition in the soft palate, if they have some mandibular, bony structural issues, then these are the patients who can get OSA. And mind you, in India, there is quite a number of patients who are non-obese OSA patients because of basically a narrowed upper airway, which is very common. So these patients, as the age increases, so obviously you look at them, they don't look obese, and you may not suspect OSA, but they have structural issues, and moment they are even 3 to 4 kgs overweight, they may have obstructive sleep apnea. So obstructive sleep apnea is actually a spectrum. So quiet breathing is absolutely normal. Intermittent snoring is very common. All of us have snored once in a while when very tired. But when it becomes chronic and habitual snoring, that's when actually the symptomatology of obstructive sleep apnea starts. Okay? Then initially there is just upper airway resistance syndrome, then mild obstructive sleep apnea. If untreated and patient continues to gain weight, it can become moderate OSA, severe OSA, ultimately with very high BMI of more than 38, person can have obesity hypoventilation syndrome. Okay, so what pushes the patient up on the spectrum is age, weight, use of alcohol, sedation, and sleep deprivation. So we must be aware of all these factors in your obese patient with higher age, and when you use perioperative medication and sedation. So that is when a person with just upper airway resistance syndrome or mild OSA may precipitate into moderate or severe OSA. So etiology of OSA, various structural issue. Of all these etiology, the commonest is palate, elongated or enlarged soft palate, fat deposition, narrowing of the hard palate, macroglossia, retrognathia, and micrognathia. Other things are more common in pediatric population: nasal deviated septum, bilateral polyps, bilateral turbinate hypertrophy. Adenoids in children is a very common etiology for OSA, enlarged tonsils, and that's why in children, surgical option of removing adenoids and tonsils can actually cure them of OSA, and nasopharyngeal tumors. So you can see here the structural assessment is very important. Sideway examination. This patient, he was patient of ischemic heart disease. You can see here the chin is little small. It is there is retrognathia also. He has a short neck. He was actually my doctor friend's father. He got diagnosed with ischemic heart disease, had to undergo CABG. On table, they could not intubate the patient, and so patient was shifted to higher center. Patient was brought to Jupiter Hospital. Again, we tried intubating the patient, could not. So endoscopic evaluation was done. On endoscopy, we found that there was a lot of upper airway edema, and patient obviously had sleep apnea. So we did the sleep study, we did the titration, and asked this patient to use positive airway pressure for about a week. That helped to reduce his airway edema. Then we could intubate this patient and successfully perform the surgery. And after the surgery, he was advised to use PAP therapy routinely. This lady, you can see a very small chin and a significant retrognathia. She used to work in bank, and she would sleep off on the, while accepting the checks. I noticed that. I asked her and told her that this is a disease, not, that's not a normal condition. She got herself evaluated, and her index was very high, more than 50. She started using CPAP and had significant improvement in her health. So coming back to etiology of OSA, obstruction can be more than one level. This is especially true in our obese patient, because they have excessive subcutaneous fat. They also have large tongue, so visceral fat, excess fat in the soft palate, reduction in the lateral diameter of airway due to increase in parapharyngeal fat. So all these factors put them at much higher risk of developing OSA. It's a very interesting image of patient with OSA. You can see here the size of the airway and the size of the airway here. Again, here a normal patient where you can see the retropalatal and retroglossal space, and see that significant reduction in the space is seen here. And here you can make out subcutaneous fat. Okay. So what actually happens in an apneic event? So there is occlusion of airway. This leads to physiological disturbance. Large swings in the intrathoracic pressure, and in sleep there is occlusion of the airway. This leads to large swings in the intrathoracic pressures. There is increased sympathetic activity, one because of this effort, and secondly because of hypoxia. This leads to increase in blood pressure as well as pulse rate. Hypoxia, hypercapnia also contributes to this, and all this leads to arousal from sleep and sleep fragmentation. So 3 three mechanisms are most important to explain all the comorbidities happening because of OSA. So apnea and hypopnea. Apnea is absolute absence of breathing for more than 10 seconds, and hypopnea is reduction of 70% or more in breathing associated with 4% dip in oxygen saturation. So what happens when patient has apnea hypopnea? It leads to hypoxemia. It leads to swings in the intrathoracic pressure. This, as well as sleep fragmentation, all three lead to sympathetic surge, which causes hemodynamic effects on the cardiovascular system, is responsible for oxidative stress, inflammation, endothelial dysfunction, and hypercoagulable state. And that explains all the complications of OSA like hypertension, coronary artery disease, pulmonary hypertension, heart failure, pulmonary embolism, diabetes, insulin resistance, and sleep fragmentation leads to poor quality of life, accidents, and cognitive dysfunction. So, obstructive sleep apnea is a risk factor for hypertension, ischemic heart disease, stroke, diabetes, cardiac arrhythmias, cardiomyopathy, congestive heart failure, and a lot of perioperative complications. So, with this brief introduction on OSA and understanding the pathophysiology and why do you get multiple comorbidities and why should you expect multiple complications when the patient of OSA is not treated, let's come to all the perioperative issues and what are the guidelines saying. So American Society of Anesthesiology guidelines, very well formulated guidelines are there. So there starts with pre-op, intra-op as well as post-operative management of OSA patient. So for pre-operative evaluation, the most important is when you first time assess your patient for any form of surgery or a procedure, endoscopic procedure, then these are the things you are supposed to go through. So first of all, important to go through the medical record, interview of the patient and family. You must have the screening protocol, physical examination, and the gold standard is diagnostic sleep study or polysomnography. So these guidelines were published in February 2014. So medical records, you must go through the records for finding out pre-existing OSA. So number of our patients actually have a and they have a sleep study done, but they never come back for titration evaluation because they are not comfortable with the idea that they have to use CPAP. So they just disappear, they put on more weight, and then they come back for one of the surgical procedures, and unless asked, they would not show the earlier report. So it's very important to ask whether patient has ever undergone sleep study. Then commonly associated comorbidities, diabetes, obesity, cardiovascular, arrhythmia, hypertension, depression. If patient has this comorbidities, one should suspect OSA in these patients. Previous history of OSA related perioperative issues or difficult airways. Okay, so must specifically ask for these issues in previous surgeries. Then how do you take the history of the patients? Very important to go through this history in adults. Ask for loud habitual snoring. Almost every day patient is snoring, and this history you will get more from the spouse or bed partner. Witness apnea, whether actually patient stopped breathing and had to be awakened from sleep. Sometimes it is so severe that patient wake up and they remember these choking episodes. In nocturia is a very common symptom of sleep apnea. Daytime sleepiness, lethargy, mood swings, lack of concentration and focus, memory lapses. Sometimes patients have depressive features because of this lethargy and fatigue, and they are put on antidepressant medicines, and which worsens the sleep apnea actually. In children, you get a different history, restless sleep, snoring, struggling in sleep, sometimes sleep talking or night terrors. And they sleep in unusual position, patient with tonsils and adenoid, they sleep in unusual position, sleepy in the daytime, and easily distressed and aggressive, irritable. So this history you should obtain for pediatric patient. Stop bank, Dr. Bhavesh has already discussed, so quickly I'll go through 1 point for every. Yes, snoring, tiredness, observed apnea, high blood pressure, BMI more than 35, age more than 50, neck circumference more than 40 centimeter, and male gender. So each yes gets 1 point. So when the score is 3 or more, the chances of OSA increases. So 0 to 2 is considered low risk, 3 to 5 is considered moderate risk, and 5 to 8 score very high risk, more than 90% chance of this patient having moderate to severe OSA. So it's a very simple screening tool, and I think you can do it for all your patients. Then comes the physical examination. Of course, in your pre-op evaluation, this is a very important evaluation that you must be doing for all your patients, especially from OSA point of view. What's important? Tongue size, Mallampati score, tonsils, nasal cavity, mandible, soft palate and uvula, neck circumference, presence of pedal edema, facial puffiness because of little raised right heart pressures, and BMI. This is Mallampati score. This macroglossia, many times, patient with large tongue, they have teeth mark on their tongue. So that gives us a clue about macroglossia. You can see here retrognathia as well as micrognathia. This patient has again retrognathia, and this patient underwent mandibular advancement surgery, and you can see the increase in the size of the airway. In children, tonsils and adenoids. So this is how a polysomnography report looks like. So you may not be able to read this, but you must be aware that what features a well-conducted polysomnography should show you stages of sleep. These red marks are showing the REM sleep. Okay? And this is the oxygen saturation level. This is about the arousal, and these are the events. So obstructive event. So this is how the graph looks like. And then what information you get is very important, that is AHI index. So apnea hypopnea index. So anything less than 5 per hour is considered normal. Mild OSA is 5 to 15, moderate OSA is 15 to 30, severe OSA is more than 30 per hour, and anything more than 40 should be considered as life-threatening OSA. Now here in this patient, you can see the apnea hypopnea index is 45.5. So that's in red zone. But that's a life-threatening OSA, and this must be treated. So how a report is done? It mentions about the sleep efficiency, 98.5%. How much was REM sleep? How much was non-REM sleep? This is apnea hypopnea index. And then the lowest oxygen saturation recorded was 63%. Mind you, this tells you the severity of OSA and potential life-threatening complication arising in sleep. And snoring was severe through the diagnostic part. So the conclusion is sleep disorder breathing with severe OSA leading to severe oxygen desaturation and sleep fragmentation. And then you recommend titration study. So we at Jupiter Hospital have a state-of-the-art sleep lab, and we are developing a center of excellence, and this is how a well-conducted sleep report should look like, because a number of sleep studies are done on home basis and many people do it, but unless it is done well, you'll not get the adequate information. So now let's come to perioperative scoring system. So when you are assessing your patient of sleep apnea, you must know, you must answer the surgeon, you must answer the patient and the family that how risky is the procedure. So you must have some scoring system of risk stratification. So if you have a sleep study available, then yes, you can score. If it's normal 0, mild 1, moderate 2, and severe is scored as 3. So that depends on your AHI index. Then the second part of the snoring is how invasive is the surgery and anesthesia. So if it's superficial surgery under local or peripheral nerve block without sedation, then no risk. Superficial surgery with moderate sedation, then the risk is 1. Peripheral surgery with spinal or epidural with no more than moderate sedation, then point is 1. Peripheral surgery with general anesthesia, then the score goes high, 2. If it's airway surgery with moderate sedation, then score is 2. If it's a major surgery with general anesthesia or airway surgery with general anesthesia, then your risk score goes higher to 3. The third consideration is requirement of post-operative opioids. So if no opioids are required, then is 0. If low dose oral opioids, then 1. But if you are requiring higher dose, either parenteral or in your epidural, then the score goes 3. So how do you estimate the perioperative risk then? Mind you, this is so this guide, they have not much validated in the clinical studies, but this is a guidance. So if you find this useful, then maybe you could try in your patients and try to stratify their risk. So it's only a guide, not a clinically validated scoring system. But if score is less than 4, then there is lower risk of perioperative complication. If score is more than 4, then there is increased risk. And score of 5 to 6, there is significantly increased risk of perioperative complication related to OSA. Interestingly, if patient is already diagnosed with OSA and using CPAP or BiPAP, then you subtract 1 point, because if patient is already using a PAP therapy, then his risk goes lower. And also in this patient, you must do ABG, resting PaCO2. If it's more than 50, then either he has associated comorbidity like COPD, or the patient also has obesity, hypoventilation. Then you have to add 1 point. Then what are the recommendations for pre-operative evaluation? So you have to sensitize your surgery friends that early referral for anesthesia fitness is very important. Most often, as is experience of our physician and you anesthesia team also, that most of the time, few hours before the surgery, we get the referral, and then they get very annoyed if we fire their case. So we also get very scared, to fire their case. So ultimately, everybody wants to please everybody, and then you end up having complication at hand. So it's very important to sensitize your surgical colleague for early reference. And in these obese patients, surgeon, anesthetist, pulmonologist, general physician, because they have multiple comorbidities, and intensivist, they have to work together. Many times such high risk patient, we have a multimodality meet before the surgery is done, and sensitizing the patient and family also. So that's very important. Counseling patient and family members extremely important, and pre-operative preparation and evaluation. So if you don't feel comfortable, you can counsel the surgeon first and then the patient that it's okay to wait and optimize the patient. So in your perioperative management, what are the points to be considered? Whether you can manage patient inpatient or outpatient, that's a consider. It's maybe for minor procedure, daycare procedure, or for endoscopic procedure. It depends on OSA severity. What are the abnormalities, anatomical and physiological? What is the type of surgery or type of procedure? What is the type of anesthesia? Whether you are going to need post-op opioids? What is the age of the patient and the comorbidities? And what outpatient facilities or support patient has. So considering all these issues, you have to decide. If it is risky, then do not manage this patient as outpatient. You, even for endoscopic procedure, you can admit this patient and do the procedure. So pre-operative preparation. So this is very important. Assess and do the risk stratification. After counseling the family, pre-operative PAP or NIV therapy has to be advised. So you must advise patient to have appropriate diagnostic and titration sleep study. Sometimes it's not possible. Either the sleep study is not available, or surgery has to be done the next day, or you don't have much time to optimize the patient. Then you refer the patient to pulmonologists and sleep specialists. So what we do here is called auto BiPAP. So we haven't titrated the patient and we don't know the actual pressure, but we can have setting of auto BiPAP, which and we set up a range. So in that range, the pressures are usually adjusted, and patient do well And after the patient is been operated and patient is discharged, and after a few days, we can do a formal diagnostic and titration sleep study and find out the actual pressures. But rather than not giving NIV therapy, it is better to give them auto BiPAP. Even 2 or 3 days of use of auto BiPAP would improve their airway edema, will improve their outcomes post-operatively. Okay? Pre-operative use of oral appliances and mandibular advancement surgery. So this is what we are not doing commonly, using oral appliances or actually doing the surgery to improve their HI, and then after a while, after optimizing, after few weeks, then you do the surgery. Perioperative, pre-operative weight loss, this has already been talked about. Rehabilitation of the patient and optimizing the comorbidities. So when you have an option, patient and the surgeon agrees, and you can wait for a while, a few days or few weeks, then that's the best thing to do. You optimize the patient on all the fronts and then take this patient for surgery, and you would be in a much more controlled setting and avoid the complication. So that was about pre-op. Let's come to intraoperative management. So choice of anesthesia is what you need to decide, the airway management and patient monitoring. Okay. Here again, the literature is insufficient, but these are the opinions of the ASA members and consultant. So they agree that potential for post-operative respiratory compromise is the main deciding factor for choice of intraoperative medication. So if you have stratified your patient beforehand, then you know which patient is more likely to have post-operative complication related to OSA, and accordingly you will choose your anesthesia as well as the intraoperative medication. So the recommendations are superficial procedure, if you can do with nerve blocks with or without sedation, that's the best. Patient with prior use of CPAP or NIV should use them during the surgery also. So if it's not a general anesthesia, then you encourage use of CPAP or NIV during the surgery. Spinal or epidural for peripheral procedures is preferred over general anesthesia. But sometimes the situation is that if you have to give mild sedation, then giving general anesthesia is much more preferable, because you have a secure airway, and especially when you need sedation, you would not like to have an unsecured airway, because sometimes this patient can really give you trouble and the airway collapses, and if you are not able to intubate them, then patient can have hypoxic brain damage or even loss of life. Extubation while awake. So this is very important. When you reverse your extubation should be done while awake, and after verifying that full reversal of neuromuscular block is happened. And preferably after extubation or during extubation, and once patient wakes in the recovery area, it should be in lateral position, semi-upright or other non-supine positions. So that's very important. So just to discuss post-operative management of OSA. So we looked at pre-operative assessment and optimization, we looked at intraoperative management, and now coming to post-operative management. So I think somebody's somebody's unmuted himself or herself, and its background sound is coming. So the consideration is about post-operative analgesia. So as far as possible, avoid systemic opioids, use nerve blocks for pain relief, and if you are using epidural, then use maybe non-opioid agents, use NSAID for pain relief, and definitely avoid concurrent sedatives, because sometimes these patients are restless and we end up giving them sedatives, and it can precipitate airway collapse and respiratory depression. Then patient positioning, as far as possible, either lateral, prone, upright or semi-upright. Okay. Then how do you manage the oxygenation? So giving oxygen supplementation is one way if patient has mild to moderate OSA, but if patient has severe OSA or moderate OSA, then for keeping the patency of the airway, it's CPAP or NIV, which is going to help in oxygenation. Sometimes we have to take an option of intubating the patient and giving mechanical ventilation. Very severe OSA patient, many times Even after post-op extubation, they have had to be re-intubated. So till the time the airway edema settles and they improve, we have to do intubation and mechanical ventilation. So delayed extubation can happen in these patients. So sometimes we have to wait for the airway edema to settle, for the general condition to improve. So many of these OSA patients, we electively delay the extubation to avoid complication. Then you need to closely monitor these patients. So either you keep the patient in ICU or high dependency unit, or if the patient has mild thing and you have done your risk stratification, then you can manage the patient in the ward. But even in the ward, you should encourage monitoring the oxygen levels. So pulse oximetry, arterial blood gases, end tidal CO2, and clinical monitoring. And so all these have to be issues have to be managed post-operatively. So just in the end of the top few slides, I would like to discuss a case. A 45-year-old male with obesity, BMI of 37 kg per meter square. He was posted for bariatric surgery. Pulmonology reference to our team was given for fitness in June 2022, just few days back. On evaluating the history, there was severe snoring, daytime sleepiness, tiredness, witness apnea by wife, and morning headaches. He had short neck circumference of 19 inches, Mallampati score of 4, and deviated nasal septum. So applying the stop bank, snoring 1, tiredness, observed apneas, didn't have BP, BMI high, he was less than 50, neck more than 17, and gender male. So his score is 6/8. So he was definitely high risk for developing moderate or severe OSA. His sleep study was done in, so going through patient record, sleep study was done in 2019. AHI was 81 per hour. He did not use CPAP, neither did he follow up, and he progressed only in one front, that he gained 20 more kgs in 3 years. Routine pre-op CT showed that before bariatric surgery, showed that he had a lesion in head of pancreas. So he was posted for US guided biopsy. He was just given mild sedation for ultrasonographic evaluation of endoscopic ultrasonography. On mild sedation, he desaturated up to 67%. So procedure had to be stopped. Then he was reversed. Same night, he agreed for a titration study, because now without that, he would not have undergone bariatric surgery. So we titrated his pressure, 17 centimeter of IPAP, and EPAP, that is expiratory positive airway pressure of 11 centimeter. And he was initiated on BiPAP, started using it from next day. Same afternoon, he was electively intubated and EUS was done. And post procedure, he has been using BiPAP. Now he is posted for surgery on 3rd July. So this is how patient has to be assessed, evaluated, sometime postpone the procedure, optimize, encourage the use of PAP, and then subject him to surgery. So just simple algorithmic management, and just overview of what we have learned in this today's session. If your pre-op patient is previously diagnosed with OSA, if the answer to this question is no, then you do this sub-bank. Okay? If your score is equal to or more than 3, yes. So if your score is less than 3, no, then fine. This patient has low risk for having OSA, then this patient can undergo surgery. The patient has low risk. Okay? Now, if the patient's score is more than 3, then you must get a new sleep study done, or if you have old report available, then ask a question whether patient has any uncontrolled comorbidities. If there is yes, that means patient has uncontrolled comorbidity. Delay the surgery if possible. If it's not emergent, optimize OSA management as well as optimize the management of the comorbidities, and post the patient for surgery at a later date. Now, if patient does not have a uncontrolled comorbidities, then you can post this patient for surgery. And you must use the strategies for perioperative risk minimization, like perioperative positive airway pressure use, and then post-operatively encourage this patient to follow up with the sleep specialist. Now, coming here, if the patient is diagnosed with sleep apnea previously, he already has the study, yes. Then, does the patient have titration report? If the patient has titration report, what was the NIV setting? What was the pressure advised? And is the patient using according to this pressure? If the patient has been using PAP, yes, then the risk is already optimized. Continue the PAP use perioperatively and proceed with surgery. So this is how you proceed the patient, finding out the risk stratification and whether the patient has been using the PAP therapy or no, and then take a decision whether you can go ahead with the surgery. If you go ahead with surgery, what intervention you should do, and if there are multiple comorbidities and completely untreated OSA, then preferably delay the surgery. So just my last slide. Take home message: with the rising obesity pandemic, number of preoperative patients with high likelihood of OSA has significantly increased. Undiagnosed and untreated OSA patient can develop serious and life-threatening pre-op, intra-op, and post-op complication. Following the guidelines, an algorithmic approach can minimize the perioperative risk. Anesthetist, surgeon, pulmonologist, general physician, and intensivist should work as a team for perioperative management of OSA and related comorbidities. And a good quality diagnostic sleep study and titration study followed by positive airway pressure therapy is essential for optimal outcome of OSA patient. Thank you so much for your patient hearing. I hope this talk is useful, and if time permits, I would be happy to take the questions.
Thank you so much, madam. That was absolutely lucid talk, and it was so comprehensive and clear that I don't think there are any questions in anybody's mind. So it is very important to keep in mind non-obese OSA, and very important to have collaboration with surgeon, pulmonologist, and anesthetist. Thank you so much, madam. There are a lot of take-home messages which you have mentioned in your last slide. So thank you so much once again. And if we have any questions, we'll get back to you.
Sure.
Okay. I think now we have done the pre-operative assessment and evaluation, and we have optimized our patient with madam's help. So now we will go ahead with induction of anesthesia. So for that, I'm going to call Dr. Parna Thakkar. Dr. Parna Thakkar is MD, DNB, FCPS, FICM. She has done fellowship in critical care, postdoctoral fellowship in neuroanesthesia from USA. She has over 26 years of clinical experience. She is treasurer of Thane ISA. She is governing council member of ISA. She has more than 40 national and international presentations and publications. She has special interest in neuroanesthesia, liver transplant, bariatric anesthesia, and labor anesthesia. She is currently working as consultant in Sir H.N. Reliance Foundation Hospital, Mumbai. Over to you, Parna, for intraoperative management and extubation strategies for obese patients.
Thank you so much for the kind introduction. I'll just share my screen.
Yes.
Am I audible? My slides are visible?
Yes, yes, Parna.
Okay. So thank you, ISA Thane, for giving me this opportunity Good evening, friends, colleagues, and seniors. Greetings from Sir H.N. Reliance Foundation Hospital, and I'll be speaking on intraoperative management of obese patient. Wow. If you have to anesthetize this kind of obese or morbidly obese patients, it's a challenge. If you can see this WHO classification, as the BMI increases, the ASA grading also increases and the risk of perioperative morbidity and mortality also increases. When the BMI is more than 40, they fall into ASA 3 category. So to anesthetize these patients, we need expertise, special equipment, and trained personnel. It's always better to have 2 trained anesthesiologists while anesthetizing these patients. So the special challenges faced in obese patients are the venous access could be difficult. Ultrasonography can be used to place the IV line. Airway management, ventilation, hypoxia, and desaturation are the main concerns while anesthetizing obese patients. There's also a possibility of risk of aspiration, which has to be kept in mind while anesthetizing obese patients. Positioning, monitoring, choice of anesthetic technique and agents, fluid management, and pain control are the other challenges in obese patients. Now, to face these challenges better, and to increase patient safety, we need to adequately prepare the OT before we take these patients in the OT. So they will need special beds. So high capacity special operating tables should be available. Now, this is a picture from my hospital operation theater table, which says that the maximum load capacity that the table can take is 455 kg. So before taking in these patients, confirm that your OT table can take the weight of the patient. Have the shoulder, leg, and foot support available. Also, table extension should be available if the patient is too obese to accommodate the patient well on the OT table. Straps are very, very important for immobilization and positioning of these patients. Difficult intubation cart with bougies, stylets, and fast track LMA need to be kept ready. Oropharyngeal and nasopharyngeal airway of suitable sizes should be available. Video laryngoscopy has almost replaced the fiber optic intubation in obese patients. Video laryngoscope has become the gold standard technique for intubating obese patients, and a D blade should be available. However, fiber optic scope and front of the neck access equipments have to be kept ready. Also, we must keep it in mind that in some of these very obese patients, front of the neck access may be extremely challenging and very difficult. Also, if the patient is using home CPAP or BiPAP, have the machine available in the OT and get familiarized with that machine. Otherwise, if you want to use it at extubation, you will not know how to use it. Sometimes the cords are missing, they've not come from the ward. So get used to that CPAP machine if you want to use it during the surgery and have it available. Difficult ventilation and intubation should be expected when the Mallampati score is more than 3 or the neck circumference is more than 42 centimeter or if the BMI is more than 50 kg. Also, if the stop bank score is high, ventilation or intubation could be difficult. Patients who have beard, the mask holding itself is difficult and that can make the ventilation difficult. So be aware of and anticipate difficulty in ventilation and intubation while anesthetizing these patients. Now, this is a NAP4 study from UK, and it said that endotracheal tube provides a definitive airway and is preferred for BMI over 40. Also, it reveals that incidence of adverse event doubles up when supraglottic airway devices are used in obese patients. Here in this picture, please note the shape of the endotracheal tube. It should be shaped in J shape with a stylet loaded if you're using a D blade. So if you're using a D blade, the curve has to match with the curve of the D blade and have the endotracheal tube in J shape, and put the stylet in and get the shape right. Monitoring. In addition to routine monitoring like ECG, pulse oximetry, NIBP, and ETCO2 monitoring, temperature monitoring is also very important in obese patients. Note the baseline SpO2 when you take the patient in the operating room. NIBP cuffs of appropriate sizes should be available. ETCO2 monitoring is very, very important for confirming the tube placement after intubation. Neuromuscular monitoring is important in obese patients. This monitoring gives us guide about the depth of anesthesia, and the incidence of awareness increases in bariatric patients. So that is why BIS monitoring is also very important. Urine output monitoring, invasive arterial BP monitoring, CVP, and cardiac output monitoring can be done in indicated cases. Now, this is a study which is published in Obesity Research Journal, and they compared the intra-arterial blood pressure with the forearm blood pressure. And they suggested that the forearm method is also very reliable, and it's an accurate alternative to the upper arm measurement to assess the blood pressure during the surgery. Now, sometimes in these obese patients, the upper arm is conical shaped, or if you do not have very large size BP cuff, or even if the large size BP cuff is not adequately fitting, it may not give you the accurate blood pressure. So if you're not happy with upper arm BP reading, please put the normal BP cuff on the forearm, and you can monitor that blood pressure, and that is also very accurate. Now, induction, shorter, as we've seen in the previous lecture, that physiological changes occur in the respiratory system of obese patients. The lung volume and the compliance goes down. So that is why maintenance of oxygen during induction and intra-op and the post-op period is a big challenge. And we should make sure that we adequately oxygenate these patients. Also, remodeling of the airway occurs, and airway is more susceptible to collapse and narrowing during induction and in the extubation phase. So prevention of hypoxia at induction and at extubation is very, very important in these obese patients. So how do we prevent hypoxia? One is positioning. We need to position these patients adequately. Also, we need to pre-oxygenate them well. And while pre-oxygenating, CPAP and apneic oxygen can be added. Now, how do we position them? So RAM position is given with 30 degrees head up, such that the external auditory meatus and the suprasternal notch, they are in one line, and the face is parallel to the ceiling. Head elevation and the shoulder elevation can be done with sheets or towels, or bolsters can be used. Also, troop elevation pillow, which are ready-made pillows, they also can be used for giving the position to these patients. Pre-oxygenation is done for 3 to 5 minutes with 100% oxygen. Monitor the end tidal oxygen concentration if that facility is available on your monitor. And it should at least increase to 85% before you start inducing the patient. So pre-oxygenate these patients well and encourage the patients to take deep breath. In case of emergency, 8 vital capacity breaths can be given. Also, intermittently ask the patient to take deep breaths. CPAP of 5 to 10 centimeter of water can be added while pre-oxygenating these patients. Apneic oxygen. Now, when you start pre-oxygenating the patient, along with that, you must add apneic oxygenation. What is apneic oxygenation? So high flow of oxygen is given at high concentration, and apneic oxygenation fills the dead space like pharynx, larynx, and alveoli. it increases the alveolar oxygen stores, and thus it delays or prevents desaturation. And also apneic oxygenation increases the safe apnea period. What is safe apnea period? Is the time between the muscle paralysis and the drop in the saturation. So in normal weight patients, the safe apnea period is 8 to 10 minutes. But in morbidly obese patient, it is extremely short, which is only 2 to 3 minutes. So to tackle this difficult airway, you'll get only 2 to 3 minutes. So along with your pre-oxygenation, which is done for 3 to 5 minutes, with that, if you add apneic oxygenation, you will get longer safe apnea period, and you will be able to tackle this difficult airway better. So these are the different techniques of apneic oxygenation. The most popular technique, which is used by most of the people and even in our hospital, is the diffusion oxygenation technique, where the nasal cannula is used. So 15 liters of oxygen is given with the nasal cannula. The other technique is high flow nasal cannula, or Thrive can be used, which gives about 30 to 50 liters, 30 to 70 liters of oxygen. Also buccal oxygenation, where the RAE tube is fixed to the buccal mucosa and high flow of oxygen is given. That also is another option for apneic oxygenation. Now, this is an article which was published in 2017 in Journal of Anesthesia and Clinical Research, and they compared the effectiveness of the nasal prongs versus the nasopharyngeal catheters for apneic oxygenation. And they found that nasopharyngeal catheters, they provided better apneic oxygenation than the nasal prongs. Now, why is that so? So they said that oxygen is distributed close to the trachea when you're using nasopharyngeal catheter, and thereby it circumvents the potential problem associated with the nasal prongs when the airway patency is not maintained. So you are giving, say, 15 liters of oxygen through nasal prong, but if there is obstruction of the nostril, then your oxygen is not reaching the alveoli. So if you give nasopharyngeal apneic oxygenation through nasopharyngeal catheter, which bypasses the nostril and it is close to the trachea, that will give you better apneic oxygenation. Now, as you can see in this slide, we all know that obese patients are at increased risk of regurgitation for various reasons. Now, this is the study which was published in British Journal of Anesthesia and in 2020. And it says that rapid sequence induction should not be a routine in adequately fasted obese patients. So we feel that the risk of regurgitation is high. So should I give rapid sequence induction or cricoid pressure? No. If the patient doesn't have any other abnormality like intestinal obstruction or anything like that, then, and if the patient is adequately fasted, you do not need to do rapid sequence induction. So what is the optimum NBM required for obese patient? It is same as normal, that is 6 hours. And you can give clear fluids 2 hours prior to the surgery, and you can practice ERAs, you can give carbohydrate oral loading 2 hours before the surgery. But if the patient is diabetic or has some other pathology where you expect delayed gastric timing, then maybe the fasting could be more. Induction agents. Shorter induction agents like fentanyl and propofol are preferred. Succinylcholine or rocuronium can be used for intubation. Dexmedetomidine, which is alpha-2 agonist, has opioid-sparing analgesic property, and it is preferred in obese patients as it does not cause respiratory depression. Atracurium or cisatracurium is a muscle relaxant of choice for maintenance. Now, how do I dose the obese patient? It is really confusing, and there are lots of formulae, and we need to get better understanding of how to dose the obese patients. So generally, the dosage of the anesthetic drug is usually based on the ideal body weight or the adjusted body weight, except succinylcholine, which is dosed according to the total body weight. We are aware of this fact. Now, ideal body weight is very, very easy to calculate. Height in centimeter minus 100 in men and height in centimeter minus 105 in women. So that is the easiest formula for the ideal body weight. Now, if the actual body weight or the total body weight of the patient is more than 30% of the ideal body weight, we should not be using ideal body weight for dosing, but we should be using adjusted body weight. Now, what is the adjusted body weight of the patient? It is the actual weight, that is the total body weight of the patient, minus the ideal body weight into 0.38 plus the ideal body weight. Now let's make it more clear. I'll give you an example. Now in this example, the patient's actual body weight is 120 kg and his height in inches is 65 centimeter, which comes to around 162 centimeter. And his ideal body weight, as we saw in the previous slide, that is height in centimeter minus 100 in men. Okay, so this is the ideal body weight of the patient. So here the ideal body weight of this patient, because his height is 162, so 162 minus 100, so 61.5 kg is the ideal body weight. Now patient's actual weight is 120 kg and his ideal body weight is half of his actual body weight, which is 61 kgs. Okay, so now if you were to give the drugs according to the ideal body weight, you would be underdosing the patient. So that is why we need to give the dosage according to the adjusted body weight. So here, as I told you, the percentage of the ideal body weight in this patient is 95% above the ideal body weight. So this patient's actual weight is 95% more than the ideal body weight, and we should be giving the drugs according to the adjusted body weight. The adjusted body weight formula I gave you in the previous slide, which comes to around 84 kg, 84.9 kg. So he's 120 kg and we should be giving the drugs according to 85 kg, whereas his ideal body weight is 61 kg. So patients where the ideal body weight is more than 30% of the actual body weight, we should use adjusted body weight. Now, what is lean body weight of the patient? It is the body weight minus body fat, but it is difficult to calculate body fat. So here, I just wanted to note one thing, that patient's actual weight is 120 kg, ideal body weight is 61. The lean body weight is slightly more, that is 68 kg, and the adjusted body weight is 84 kg. So that is more. So it is more, more approximate, and you would be dosing the patients more accurately if you use adjusted body weight in the patients who are more obese than actually thought. Now, highly lipophilic drugs like succinylcholine are given as per the total body weight. Less lipophilic drugs like non-repolarizing muscle relaxants are given according to the adjusted body weight. Antibiotic dosing is done as per the total body weight of the patient, and underdosing or the overdosing of the drugs should be avoided. Now, this is an article from Journal of Anesthesia in 2012, which shows that propofol was used for induction as the lean body weight. So either you can use lean body weight or the adjusted body weight if the ideal body weight is more than 30%. So either use lean body weight or adjusted body weight. So propofol was used as lean body weight, maintenance dose was given as per the total body weight, and succinylcholine was used as the total body weight. Now, dosing of emergency drugs like noradrenaline and adrenaline should be according to the ideal body weight. Now, atropine should be given according to either adjusted or the lean body weight, because if you underdose atropine, it will cause bradycardia. So always keep it in mind that atropine should be given either according to the adjusted or the lean body weight, and noradrenaline and adrenaline as per the ideal body weight. Maintenance. We have two options for maintenance. One is inhalational agent and TIVA technique. Now, inhalational agents like desflurane and sevoflurane are more suitable in obese patients. Desflurane is the least fat soluble and it promotes the rapid return of the airway reflexes. So it is preferred over sevoflurane in morbidly obese patients. So if you have desflurane available, use desflurane over sevoflurane. Nitrous oxide should be avoided as it causes bowel distension. Propofol and dexmedetomidine based total intravenous anesthesia is another choice and is practiced in many bariatric centers for maintenance instead of the inhalation agents. So if you don't want to use inhalation agents, you can just use a combination of propofol and tiva. And if you want to use little bit of desflurane and little bit of propofol, dexmed, anything is okay based on the response of the patient. Now, fluid replacement is another confusing topic in bariatric patients. There are two schools of thought. One is the liberal and one is the restrictive approach. So in liberal, 40 ml per kg per hour of the fluids, crystalloids are given as per the total body weight, and restrictive approach, 15 ml per kg per hour of the fluids are given as per the total body weight. But if you use liberal fluids, liberal approach, you will end up giving so much of IV fluid to the patient, and that may be detrimental to the patient. So that is why nowadays what is most advocated is the goal directed therapy, where the fluids can be given according to the vital parameters and the stroke volume variation and the fluid responsiveness of the patient. Maintenance fluid should always be calculated based on the ideal body weight. Now, if this obese patient comes for a bariatric surgery, those patients would be on liquid diet for some time, or if the patients are fasted for a long period, like if they come for short procedures like colonoscopy or something like that, where they are given enema, they would be more dehydrated. So the initial fluid should be given according to the response of the patient. So if the patient is becoming hypotensive and if the patient is lower on the intravascular volume, you can give little bit more of the fluids, but then during the maintenance, once you've covered up the deficiency, then give the fluid according to the ideal body weight. Now, this is the trial which was published in 2012, and they compared two groups of patients where they gave 10 ml per kg per hour of the crystalloids, and the other group received 4 ml per kg per hour of the crystalloids according to the total body weight. And they found that reduced complication rate with the group where the lower volume of the fluid were given, and they concluded that the small volume of fluids may benefit the patient without adversely affecting the renal function. Now, when we are dealing with these obese patients, there are two things in our mind, two post-operative complications. One is rhabdomyolysis and acute renal failure in the post-op period. So sometimes when we give less fluid, we are worried about the acute renal failure in the post-operative period. But this study says that even if you give restricted fluid, there is no problem, and the renal function doesn't really get affected if you're giving restricting fluid. And the best is goal-directed therapy. Now, this is the ERAS Society recommendation, which were published in 2016. And they said that excessive intra fluids are not needed to prevent rhabdomyolysis. We all feel that the treatment for rhabdomyolysis is IV fluids, liberal IV fluids, or if we feel that if less fluids are given, it can lead to rhabdomyolysis because of the pressure on the muscles in the obese patients, but that is not so. So excessive intra fluids are not needed to prevent rhabdomyolysis and maintain the urine output. And ERA study, which was published in 2016, they also recommend goal-directed fluid therapy. Intraoperative ventilatory strategy. We all know that obese patients are prone for basal atelectasis soon after induction. As you can see in the CT image, that very soon after intubation, the atelectasis has developed at the base of the lungs. So once the alveoli have collapsed due to atelectasis, application of PEEP alone will not reopen them. So recruitment maneuvers allow the alveoli to be reopened and recruited. It is therefore recommended to apply PEEP in the beginning along with the recruitment maneuvers all through the intraoperative period, preferably every 30 minutes. So during the surgery, if you're giving only PEEP and not recruiting the lungs, every 30 minutes or every 20 minutes or at regular intervals, you will definitely have more of atelectasis post-operatively, and you will have more complications in the post-operative period. So if the BP of the patient allows, please do regular recruitment maneuver along with PEEP. Now, this is a trial which is called as an improved trial, which compared the protective ventilation with the non-protective ventilation. So in protective ventilation, tidal volume of 6 to 8 ml per kg of the ideal body weight was given, and PEEP and recruitment maneuvers were given. PEEP of 6 to 8 centimeters of water was given, and the recruitment was done every 30 minutes. So this is the protective ventilation, and that was compared with a non-protective ventilation, where only tidal volume of 10 to 12 ml per kg of the ideal body weight was given without PEEP and without recruitment. And they concluded that protective ventilation reduced the overall complication rate from 27 to 10% and reduced the hospital stay by 2 days. So it is always better to recruit the lungs at regular intervals during the surgery. Now, what is recruitment maneuver? It is the continuous inflation technique. So continuous positive pressure is given at 35 to 40 centimeter of water for 30 to 40 seconds. How do we do it? So just remember the rule of 30. So 30 centimeter of water for 30 seconds, APL valve is closed at 30 centimeters of water, and it is given every 30 minutes during the surgery. So that's a rule of 30, which I thought of while making this presentation. Now, also in newer ventilators, there is a procedure mode available that can deliver vital capacity, and the duration of the vital capacity can be adjusted, and that mode also could be used to recruit the lungs. Recruitment maneuver using bag squeezing should be avoided as it causes barotrauma. So to summarize, tidal volume at 6 to 8 ml per kg of the ideal body weight, PEEP of 6 to 12 centimeter of water is added to titrate according to the SpO2 of the patient, oxygenation of the patient. Recruitment maneuver, as we said, every 30 centimeter of water for 30 seconds, every 30 minutes. And also keep it in mind that the BP can fall while you are recruiting the lungs. So if the BP allows, so whenever the BP allows, recruit the lungs every 30 minutes or 40 minutes or every 20 minutes at regular intervals. Plateau pressure should not exceed more than 30 centimeters of water. Respiratory rate should be titrated according to the EtCO2 of the patient, and maintain an EtCO2 between 30 to 40 millimeters of mercury. I ratio can be adjusted, and FiO2 of 40 to 80% can be given. Now, positioning is very, very important in these patients. So spend adequate time while positioning the patient before you start the surgery. Adequate strapping is done so that the patient does not slip during the surgery. All the pressure points should be padded well with jelly or pillows so that there are no nerve injuries. The chances of rhabdomyolysis decrease. DVT Flowtron pumps are very important, and even stockings can be provided, and low molecular weight prophylaxis can be given in the post-operative period. Rhabdomyolysis. Now, this is the picture of our operation theater where the jelly pads are used regularly for preventing rhabdomyolysis and for bariatric patients. So the incidence of rhabdomyolysis is 5 to 77%. Risk factors are BMI more than 50. Males are more prone. Surgical duration, if the surgical duration is more than 4 hours, rhabdomyolysis can set in the post-operative period, which can be picked up by rise in the creatinine kinase, which is more than 1000 IU per ml. And if rhabdomyolysis sets in, there are 14%, there is increased risk of renal failure. Now, if the surgical duration is long, say 6 to 7 hours, which normally does not happen in our center, but supposing if it's a complex procedure or a combined procedure or something like that, and if the duration exceeds more than 4 hours, then pneumoperitoneum should be deflated. If it is a bariatric or a laparoscopic surgery, the position should be made neutral. There should be sufficient break should be given so that the pressure is taken off the pressure points and the muscles of the back and the legs, and then the surgery after a break can be restarted, and that can prevent rhabdomyolysis. Pain management. Multimodal analgesia is practiced to decrease consumption of opioid drugs like paracetamol, NSAIDs, acetaminophen, and dexmedetomidine can be combined with local infiltration and nerve blocks. TAB blocks are given routinely. USG guided TAB blocks are given routinely in certain bariatric centers. In our center, we are giving local infiltration along with IV PCA so that the patient is more comfortable that, okay, he has the pain control in his hand. Now, concerns at extubation. Post-extubation, these obese patients are at risk of developing critical respiratory events like desaturation, hypoventilation, and airway obstruction, and this can lead to reintubation. So the chances of reintubation in these patients are high, and it should be kept in mind when you are extubating these patients. Also, hypoxia and atelectasis are other concerns at extubation. So to avoid reintubation, just make sure that the patient is fully awake and alert at extubation. Head lift is more than 5 seconds, hemodynamically stable, he's normothermic, adequately reversed. TOF can be used to guide us for the extubation. Respiratory rate should be less than 30. SpO2 with 0.4 FiO2 should be more than 95%, and the tidal volume is more than 5 ml per kg. And the inspiratory force is more than minus 25 centimeters of water, and the patient is relatively pain-free. So if all these or most of these criteria are followed, and with your gut feeling, with your experience, if you feel that the patient is adequately lifting the hand, he's quite wide awake, then go ahead and do the extubation. But keeping in mind that rapid desaturation can occur after extubation because already they have pre-existing shunt, which can deteriorate markedly after induction or at extubation. And in these times when rapid desaturation occurs, supplemental oxygen alone may not be sufficient, and you might need to add CPAP or BiPAP. And that is when your home BiPAP or CPAP machine will come handy, and you might have to use it for immediate postoperative period. Now, multimodal approach involving posture. So at extubation, always have semi-sitting position or lateral position, as madam said earlier. If you've taught the patient breathing exercises pre-operatively, that helps in improving the FRC and the lung volumes of the patient. Physiotherapy and in some cases, as we discussed, CPAP may be needed. Now, remember this slide. 2 cheap, useful, life-saving gadgets which we have with us are bougie, which is used at induction, and airway exchange catheter, which can be used at extubation. So if the intubation is very difficult, you can extubate over airway exchange catheter, which are well tolerated. You can also give oxygen through them, and once the patient is fully awake, you can remove them after 1 or 2 hours. They'll tolerate the airway exchange catheter, and if the need for re-intubation arises, you can intubate over the airway exchange catheter. So these 2 gadgets are very, very important, and they are cheap gadgets which can be used and kept handy in the OT while extubating these patients. Also have LMAs and CPAP machine available in the OT. Now, obesity and regional anesthesia again is very challenging. There could be difficult in with difficulty in positioning the patient, difficult to identify the midline and palpate the spinous processes. Sitting position is preferred compared to the lateral position, and a longer spinal needle may be required. There are increased chances of wet tap during epidural placement, as it could be technically difficult. USG may be used to guide the block, and remember that these patients require lesser dose of the local anesthetic when you're placing subarachnoid or the epidural block. So 20 to 25% less of the local anesthetics are required compared to the normal patients. Now, from this article, that is obesity and obstetric anesthesia, I've picked up a few pearls, and I'll enumerate them. One is, if it is difficult to identify the midline, use the prominence of the C7, cervical vertebra, and the gluteal cleft to identify the midline. If you draw a line between C7 and gluteal cleft, that will approximately tell you what is the midline. Or you can ask the patient, you can touch the back of the patient and you can ask the patient whether it's going to your hand is touching to the right or the left or to the midline. That also can be used. Now, with 1.5 inch needle, which we regularly use for giving local before the spinal or the epidural, if that is insufficient to judge whether you are in the correct space or not, a spinal needle, which is 26 gauge, can also be used, keeping in mind that sometimes it is possible to get a spinal with that needle, but at least it can guide you to give local anesthesia. Sitting position with the table tilted towards the anesthesiologist opens up the space. Now, this technique I have used many a times. So you make the patient sit on the table with the legs rested on a table, footstool. And then you can tilt the patient toward, tilt the OT table towards your side. So when the patient goes forward and hugs the pillow, and you have tilted the table in the reverse direction, the spaces open up better. So this is another technique which is mentioned in that article and which I picked it up. High failure rate of epidural catheter placement. We will not believe, but it is 42% failure rate when the epidurals are put. Multiple attempts at epidural technique and the catheter placement. So sometimes even if you've got the epidural, the catheter would not go. So there could be difficulty while placing the epidural, or once you've got the epidural, even the catheter may not go. So these are the difficulties faced while giving epidural in the obese patient. Depth of the epidural space correlates with the BMI. But only a few will have epidural space which is deeper than 8 centimeters. So we always have that question, whether should I be using a longer epidural needle for placing the epidural in these very obese patients, super obese patients. So they say that use a standard needle to identify the epidural space at the first attempt, because the epidural space in most of the patient is below 8 centimeters. Now, obese parturition. Tendency for the epidural in obese patient, there's a tendency for the epidural catheter to come out. So leave adequate length of the epidural catheter in space, and it is very, very important for a working epidural catheter. Also in obstetric, in obese patients, there are more chances of operative intervention in obese parturients. So keep that in mind and make sure that your epidural catheter is working well. If you have to give GA to the obese patient, as we all know that the succinylcholine is given as per the total body weight. But in pregnancy, the activity of pseudocholinesterase reduces. So that is why the dose of the succinylcholine of 1 to 1.5 milligram per kg would be enough, and maximum of more than 200 milligrams should not be used. In post-operative period, early mobilization, thromboprophylaxis, aggressive chest physiotherapy, adequate pain control are the key success for effective post-operative care. Also, post-operatively monitor them in the HDU or a PACU, where the patient is closely monitored before shifting them to the OT. Once you are happy, you shift them to the room. And With this, I end my talk. Thank you very much for patient listening.
Thanks, Karna. That was a beautiful talk. We covered almost all topics, even confusing topics like drug dosing and intraoperative IV fluids and protective lung ventilation. So it was a really wonderful talk.
Thank you so much.
Varsha, can we have teleplex video?
Yes, ma'am. Yes.
Varsha, madam, there is no volume. There is no voice, is not there.
ते म्हटले की हे
Thank you, Teleflex, for that. Now we are coming to the last leg of.
I just wanted to tell one thing, that we are regularly using the easy block of Teleflex, and also they've come out with this beautiful technology of the where the cuff pressure can be gauged during the surgery, and also gastro LME, which from which you can pass the endoscope. So in obese patients, this could be very, very useful if these patients are posted for scopies, upper GI scopy. Thank you. Thank you.
Okay. So now we are coming to the last topic of our CME. We know that obesity and diet are closely linked. So we have thought of including this topic of role of diet and nutrition in today's CME, which will be presented by Dr. Swati Pradhan. Dr. Swati is Director, Pioneer Healthcare. She is Director, Live Light Obesity Management Center. She is Chief Consultant Anesthetist at Dr. Mukhi's Orthopedic Center. She is Consultant Anesthetist at Kaushalya Medical Foundation. She is ex-Associate Professor at TMG Science. She is ex-Course Coordinator, ISA Thane. She is member of European Society of Regional Anesthesia, and she has special interest in regional anesthesia, daycare surgery, and obesity management. Over to you, Swati. Swati?
Yeah. Yeah, Nilima. Thank you, Nilima, for my introduction. And I'd like to share my screen now. Hello, everyone. Good evening to everyone. I would like to firstly thank ISA Thane for inviting me to this talk. Actually, I was not very convinced initially that this talk would be relevant on an anesthesia forum. And in fact, I argued that why would anesthetists be interested in diet and nutrition, as we are not really involved with the prehabilitation process as such of the obese patient. But Dr. Sonali, she convinced me and she said, in fact, this is the most relevant topic in today's day and age. So here we go. Okay. So today I'm going to talk about the role of diet and nutrition in obesity. Just quickly go over some statistics. There are about 13% of the world population is obese. And in India, there's a whopping 40.3% of the population that is obese. World Obesity Day is observed on 4th March, and the theme for 2022 was Everybody Needs to Act. This classification has already been discussed. Unfortunately, it is only the morbidly obese class and class 2 and class 3 which merits a higher ASA classification, when actually we do start encountering the difficulties at a much earlier stage. Obese patients who come for preoperative weight loss are usually these which have already been told by Dr. Motwani. This this actually improves the perioperative outcome of the patient. Laparoscopic surgery, in fact, we have had a case where the laparoscopic surgery had to be abandoned because the surgeon's scopes were just not reaching the target organs, and he had not anticipated that in advance. Now, what we are interested as physicians are in the distribution of fat. There's primarily two types of distribution, that is the peripheral fat, which is the subcutaneous fat, and the central fat, or the visceral or the abdominal fat. Okay. A person is said to have central obesity if he has these parameters. This is the waist circumference, which was discussed earlier, and obviously for the Asian phenotypes, these measurements are much less. This is a DEXA scan, which shows the distribution of fat around the visceral organ. This is a good example of visceral or truncal obesity. Now, why are we worried about central obesity? Why is it such a important topic to discuss? Because this fat is highly metabolically active, and it is associated with several comorbidities like hypertension, cardiovascular disease, metabolic syndrome, and non-alcoholic steatohepatitis. And the complications along with central obesity, they increase geometrically over the age of 55 years. Central obesity is of concern because of these three issues, that is metabolic syndrome, insulin resistance, and sarcopenic obesity. What is metabolic syndrome? It is a cluster of conditions which is characterized by visceral obesity, high blood sugars, hypertension, high triglycerides, and low HDL cholesterol. You are said to have a metabolic syndrome if you have 3 out of these 5 conditions. So if your waist circumference is of these measurements, hypertension of more than 130, BP of more than 130 by 85, fasting blood sugar of more than 100, triglycerides of more than 150, and HDLs which are less than 40 in males and 50 in females. Metabolic syndrome is a major contributor to perioperative morbidity and mortality. The two main conditions in metabolic syndrome, that is diabetes and obesity, are known to have a very strong correlation, and insulin resistance is the main link between these two conditions. Now, what is insulin resistance? When we have a normal functioning insulin, the glucose is easily taken up in the target organs because they are sensitive to this insulin. Whereas when there is insulin resistance, the target organs are resistant to the action of insulin, and therefore there is decreased uptake of glucose into the target organs like the liver, skeletal muscle, and the fat. And thus there is increased glucose in circulation, which causes hyperglycemia. Okay, and therefore there is a reactive hyperinsulinemia in insulin resistance. Now, let us quickly look at the pathway of insulin signaling. What happens in a healthy individual is the insulin, it binds with the receptors, the IRS1 receptors on the target organs such as the liver, skeletal muscle, and adipocytes. And then it activates a signal transduction pathway. Once this signal transduction pathway is activated, it carries the glucose transporter, that is the GLUT4, to the cell membranes of these target organs. The GLUT4 transporter is like a gate which allows the glucose from the circulation to enter into these target organs for further glucose metabolism. Now, what happens in insulin resistance is there is dysregulation of this signal transduction pathway, that is downward from after the binding of the insulin to the insulin receptors. Therefore, there is no production of the GLUT4 transporter. As there is no production of the GLUT4 transporter, as there is no expression of the GLUT4 transporter on the cell membrane, there is no uptake of glucose from the circulation. Now, how this happens when in obesity? In obesity, there is a positive energy balance. That is, there is increased energy intake from excessive intake of calories, and there is decreased energy expenditure, that is because of a sedentary lifestyle or lethargy. Sorry. And this leads to a positive energy balance. When there is a positive energy balance, there is expansion of the adipose tissue and increased adiposity. There is lipodystrophy. This increased adiposity leads to a pro-inflammatory condition, and there is release of the inflammatory cytokines. These inflammatory cytokines then cause the dysregulation of the signal transduction pathways of insulin, and therefore this eventually leads to the decrease in the expression of the GLUT4, and therefore decreased uptake of glucose from circulation into the target organs. What happens? What happens because of this is there is insulin resistance in the target organs. Also, at the same time, the other causative factor is because of increased adiposity, there is a dysregulation of the release of the adipokines. Adipokines are the hormones which are released by the adipocytes. So these adipokines, such as adiponectin and leptin, their release is dysregulated. When the adiponectin release is decreased, it causes insulin resistance in the muscles. And when the leptin release is increased, it causes insulin resistance in the liver. At the same time, there is aggravated lipolysis in the adipose tissues, which causes increase in the free fatty acids. These free fatty acids are taken up in the liver, which leads to increased production of triglycerides in the liver, leading to the NAFLD, that is the non-alcoholic fatty liver disease, which eventually goes to the non-alcoholic steatohepatitis. Because of this fatty liver, the VLDLs are released into the blood, which eventually lead to the formation of LDLs, which lead to atherosclerosis, and therefore the condition of atherosclerotic cardiovascular disease. Thus, increased adiposity is a highly pro-inflammatory state. As you can see, this insulin resistance thus causes havoc in the body. It can lead to type 2 diabetes, hypertension, dyslipidemia, disorders of coagulation, and eventually cardiovascular diseases. What it means, what the insulin resistance means for the insulin sensitive tissues: there is decline in the glycogen synthesis in the muscle, there is a stimulation of fatty acid synthesis in liver, and there is impaired inhibition of lipolysis in the adipose tissues, leading to the expansion of adipose tissues. Now, if we see, each and every component of the metabolic syndrome is caused by this insulin resistance. Now, looking at the adipose tissues, already because of the positive energy balance, there is a hyperadiposity. There is increased amount of triglycerides in these adipose cells. Now, these triglycerides, if they have to be transported out of the adipocytes, they need to be broken down into glycerol and fatty acids, which is done by the hormone sensitive lipases. But because of the insulin resistance, there is dysregulation of these hormone sensitive lipases, and therefore the breakdown of triglycerides does not happen. Thus the adipocytes, they increase. That is, there is hypertrophy of the adipocytes, which causes increase in the abdominal obesity. Thus it's a vicious cycle where the insulin resistance leads to obesity, abdominal obesity, and the abdominal obesity, that is this lipotoxicity, in turn through the inflammatory cycle leads to more insulin resistance and diabetes. Coming to hypertension component, the insulin stimulates salt retention in the renal tubules, and this salt retention causes the retention of water, and therefore circulatory overload, leading to hypertension. There is hypertriglyceridemia in the metabolic syndrome. When a person is fed increasing loads of carbohydrates, up to a point, the person can convert these carbohydrates into glycogen in the liver. But beyond the point, when this carbohydrate intake goes beyond the point, then it goes into a de novo lipogenesis, that the liver now starts producing more of fatty acids and triglycerides. Now, this accumulation of triglycerides in the liver leads to fatty liver, and this triglycerides then produces or starts leaking VLDL into the circulation. VLDL into the circulation leads to increase LDL and atherosclerosis, and eventually the atherosclerotic cardiovascular diseases. Also, the HDL, which is the HDL, because of the the high amount of triglycerides and LDLs in the circulation, there is a breakdown of the HDL, and therefore we see low HDL numbers in metabolic syndrome. The other, apart from the inflammatory cytokines which are released because of the lipotoxicity, the other factor which is the positive factor for metabolic syndrome are the adipokines. Now, adipokines are the hormones which are released by the white adipose tissues. They are adiponectin and leptin. Now, adiponectin is actually a good hormone. It increases the insulin sensitivity of the muscle. It facilitates glucose uptake in the adipose tissue. It facilitates glucose production in the liver. It induces oxidation of fatty acids. Thus, it decreases the visceral, hepatic, and muscle fat, and it decreases systemic inflammation. Normal levels of adiponectin in the body are around 0.5 to 30 micrograms per ml. It's not milligrams, it's micrograms. Now, what happens in adiponectin dysregulation when there is in the pro-inflammatory state? There is adiponectin dysregulation. That is, there is decrease in the release of the adiponectin. Thus, there is increase in insulin resistance. There is increased plasma-free fatty acids, which eventually leads to dyslipidemia and atherosclerosis. The pharmacological treatments for adiponectin deficiency is metformin, thiazolidine diones, and prelagliptin, which shows much promise. But as far as diet is concerned, then one should include MUFA, that is the monounsaturated fatty acids in one's diet, which are usually provided by avocado, olive oil, nuts, or fish oil capsules. Coming to metabolic syndrome, the treatment is to treat the components of the metabolic syndrome. If you have hypertension, if you have diabetes mellitus, go through an endocrine reference, and dietary interventions such as the DASH diet and the liver reduction diet. The other issue that I would want to shed light on is sarcopenic obesity. What is sarcopenic obesity? What is this new term, sarcopenic obesity? It is, in very simple terms, the thin fat Indians. It is observed much in the Asian Indians. Here you have decrease in the muscle mass and there is decreased functionality in the presence of obesity. It is characterized by poor grip strength, history of immobility, and a slow gait. You often see that a patient may not weigh much on the scale. He may have a small or low BMI, but they have a very high fat percentage. So basically they are weighing less because they have a low muscle mass and not because they have low fat percentage. The fat percentage is high, but because fat is like cotton and muscles are like iron, if you have less muscles, you're going to weigh less, but the fat percentage is still quite high. So these are the sarcopenically obese. What is the pathophysiology of sarcopenic obesity? The skeletal muscle is the primary tissue for insulin-mediated glucose disposal. In sarcopenia, in the young patients, the type 1 and type 2 muscles both are affected. There is decrease in the total muscle mass, and thus there is decrease in the insulin-mediated glucose disposal. Now, if the glucose is not being metabolized by the muscles, then it is diverted to the adipose tissue, which leads to greater adiposity. There is a chronic low-grade inflammation leading to obesity associated insulin resistance. If you are observing this sarcopenic obesity in the young and the middle age, then it leads to increased insulin resistance and dysglycemia and thus type 2 diabetes. What are the causes of sarcopenic obesity? It is positive energy balance, that is actually the increased intake of calories through high fatty foods and high carbohydrate foods. There is decrease in the physical activity, low protein intake, and increased skeletal muscle fatty infiltration. There is all this leads to an altered skeletal muscle substrate metabolism. There is impaired sensitivity to the anabolic effects of insulin with associated mitochondrial dysfunction, further leading to the sarcopenia. How do you manage this sarcopenic obesity? You increase the muscle mass in the younger age groups and try to prevent the loss of muscle mass in the older age group. And this is done through diet, exercise, and lifestyle modification. Treatment of sarcopenic obesity involves diet where you give a low-fat diet, a low-carb diet to decrease the fat mass. Exercise, which also leads to vasodilatation, which increases the nutrient delivery to the muscle, and increase in mitochondrial function will further activate the skeletal muscle cells and induce development of the skeletal muscles. High quality protein should be given to the sarcopenic obese patient, 20 to 30 grams of protein per meal, and leucine should be included in the BCAA supplements. Now coming to DASH diet. Now this is the hero diet that I like to prescribe. This DASH diet is the dietary approach to stop hypertension. It is a heart healthy eating pattern. It was devised by the US based National Heart, Lung and Blood Institute to prevent and control hypertension. It is advocated as the first line pharmacologic therapy with lifestyle modification. Why the DASH diet? Now let us look at dietary components which affect the insulin resistance. You see a decreased insulin resistance on the consumption of dietary components such as fruits and vegetables, dietary fiber, omega-3 fatty acids, low GI foods, whole grains, low-fat dairy products, potassium, magnesium, calcium, and limited portion sizes. And you see an increased insulin resistance on the consumption of saturated fats, simple sugars, salt, and alcohol. Looking at this, now this is your DASH eating plan. Okay. In this is the column which shows that what you can consume, and this is a column which shows that what you need to limit. So you can consume vegetables, fruits, whole grains, fat-free or low-fat dairy, fish, poultry, beans, nuts and seeds, and vegetable oils. And what you should be limiting are the fatty meats, full-fat dairy products, sugars and sweetened beverages, sweets, and the sodium intake.
Arrangement करायला पाहिजे तिकडे ambulance in-house. We have in-house ambulance also. If you are stung by a snake, within 5 minutes, our clubhouse ambulance will reach you to the hospital.
Coming to the components of the DASH diet. Coming to the components of the DASH diet. In the DASH diet, we advocate the patient should consume at least 4 to 5 servings of vegetables, 5 servings of fruits. They should consume around 6 to 8 servings of whole grains, lean proteins.
Dr. Sumit, please mute yourself.
Let us go again to the components of the DASH diet. In the DASH diet, we advocate a healthy consumption of vegetables and fruits. Because this releases carbohydrates. These are complex carbohydrates and will not spike your sugars and insulin levels. So we advocate around 4 to 5 servings of vegetables and around 4 to 5 servings of fruits per day. We carbohydrates in the form of whole grains around 6 to 8 servings per day, and lean proteins such as phytoproteins and lean meats around 5 servings per day. Nuts and seeds can be consumed up to 4 to 5 servings per week. The daily nutrient goals in a DASH diet, we try to distribute our calories amongst the different macronutrient groups in this way. You achieve your total out of your calories, 27% of your calories should be derived from total fats, which includes only 6% of saturated fats. The remaining should be unsaturated fats. Then 18% should be derived from proteins, and 55% of your energy requirement should be derived from carbohydrates. You should have a healthy intake of potassium, calcium, and a good intake of fiber. Sodium should be limited to less than 2,300 milligrams per day. Coming to the different components of the DASH diet, how do they help in your insulin resistance and in managing the other comorbidities of metabolic syndrome? The carbohydrates, they help to carry the micronutrients and adequate energy to your tissues. In the carbohydrates, the special emphasis should be on green leafy vegetables because they are high in fiber, and fiber helps to not spike the insulin levels. And whole grains such as millets and oats are low glycemic, have a low glycemic index. Also, low glycemic index fruits like melons and citric fruits are advocated. And consumption of legumes and beans, which are complex carbohydrates. Now, fats. Now, this is the important part. The consumption of fats in a DASH diet is mainly the unsaturated fats, the MUFA, and the monounsaturated fats and the polyunsaturated fats. Monounsaturated fats can be derived. What are unsaturated fats? Basically, these are fats which are liquid at room temperature, and these do not lead to the production of excess production of the VLDLs and the LDLs, and therefore they are not implicated in the causation of atherosclerosis and cardiovascular diseases. So no, these can be derived from sources such as olive oil, avocado, sunflower oil, and nuts. And coming to PUFA, that is polyunsaturated fats, these are the essential fatty acids such as the omega-3 and the omega-6, the eicosapentaenoic acid and the decoxahexaenoic acid, which is found in the omega-3 and the omega-6, which are found in seeds. Now here you should remember that overconsumption of nuts and seeds is also not advocated because it disturbs this balance between omega-3 and omega-6. So you should have one close fist of nuts per day. That is your daily allowance of nuts and seeds. So this you can achieve through consumption of nuts like walnuts, flax seeds, and also soybean. What you should specifically avoid in the DASH diet are the trans fats and the saturated fats. So saturated fats are the fats that you derive from animal sources and high fat dairy products, and trans fats are actually the unnatural fats. These do not occur in nature, and these are procured by the partial hydrogenation of the vegetable oils. Now, why was this ever done? Why did we make these trans fats, which mainly are margarine or vanaspati, that is your dalda? It was a product of the industrial revolution, when people were trying to make food products which had a better shelf life and which were more attractive and tastier to eat, such as the bakery products. So what happens with your normal fat like oil or something, may not it does not have a high shelf life, whereas a trans fat can have a shelf life of several years, and also maintenance of crispness of the products. All your bakery products, why do you have these flaky pastries and puff pastries? Why do they stay that way? Because the trans fat, the saturated fats, they stay solid at room temperature. Therefore, they maintain their shape, and therefore these food products, no bakery product can be made without these trans fats or saturated fats, and without refined flours. So if you be the bakery products, which like such as cakes and buns and croissants and donuts, these are like the worst things that you can have when you're trying to lose weight or trying to achieve fitness. They why the trans fats are bad? They increase the LDL particles in your circulation and lead to atherogenesis. Recently, last month, there was news that somebody in the US, while renovating their house, they found a Happy Meal inside the wall of one of their when one of the walls was broken down, and inside the wall a Happy Meal was found. A McDonald's Happy Meal was found, and that Happy Meal was 60 years old, and it had not been generated. That Happy Meal, those fries which are fried in trans fats, have not degenerated for 60 years. You can imagine what that can do to your coronaries. Coming to proteins, now proteins, you can consume phytoproteins as well as proteins from lean meats, and care should be taken to not consume meats such as red meats, because they again will give rise to an increase in the saturated fats. Coming to the micronutrients, the minerals such as magnesium, potassium, and calcium are important in the DASH diet. When there is decreased intracellular magnesium, there is it leads to a vasoconstrictive effect leading to hypertension. Also, there is increased insulin resistance and increased platelet reactivity. Thus, to decrease all these effects, one should take an adequate amount of magnesium in your diet, around 400 milligrams of magnesium per day. Potassium and calcium are of course required to promote endothelial smooth muscle relaxation, and therefore this improves hypertension. Sodium. Coming to sodium, in a standard DASH diet, around 2,300 milligrams of sodium is permitted, which is around 1 teaspoon. But if you go in for a low sodium diet, then even less than that, that is around 1,500 milligrams of sodium is permitted in a low sodium DASH diet. These micronutrients can be consumed through foods such as banana, orange, spinach for potassium, orange and spinach for calcium, and whole grain, leafy vegetables, and nuts and seeds for magnesium. So In my opinion, the DASH diet is one of the best diets that one can be on because it achieves all your metabolic goals and it ticks all the boxes. It decreases insulin resistance, it decreases the triglycerides in your circulation, decreases LDL cholesterol, it decreases blood glucose levels, it decreases the inflammatory cytokines and oxidative stress, and it regulates the adiponectin levels. Thus, it is effective in metabolic syndrome, weight management, hypertension. The DASH diet has shown to decrease hypertension by almost 6 to 11 millimeters Hg systolic, and eventually also helps to decrease the risk of stroke and CRP. Thus, instead of the 1,000 who are hacking at the branches of evil, there should be one, at least one, who should be striking at the root cause, and which is insulin resistance. And I would like to come to the end of my presentation, and I hope the whole correlationship between insulin resistance, the diabetes and obesity has become clear, and now you would know for yourself how to go about taking care of these conditions and how you can minimize metabolic syndrome and sarcopenic obesity in your patients. Thank you.
Thank you, Swati. That was a very interesting talk. Thank you for enlightening us on sarcopenic obesity and DASH diet. Thank you so much. Now we are coming to the end of our CME. Before that, I would like to do an announcement. Rajiv Gandhi Medical College and in association with Indian Society of Anesthesiologists, Thane, are coming up with CME on regional and obstetric anesthesia on 17th of July, Sunday. So please register for the CME. Now we are coming to the end of the CME. I would like to thank the chairperson, Dr. Manish Motwani, for gracing our CME with his presence. And one more thing I would like to say, obesity is discussed in many webinars actually. So we were a little skeptical, but I think all our speakers did wonderful job. There was never a dull moment in the presentation. So thank you so much all the speakers. Then I would like to thank Geneca Techniques and Varsha Madam, Mr. Vishwanath from Teleflex, and I will also like to thank Dr. Rochna Bakshi, who is the MNC observer. Thank you so much, Thane ISA, Meenal Madam, Manisha Madam, for bringing this CME to us. Thank you so much. Should we conclude now, or anybody want to comment anything? Barne sir, you are there? Bhavesh, Swati, should we conclude? Parna?
Varna, what is the role of balanced solution?
Sorry?
Balanced salt solution for intraoperative management?
Balanced salt solution.
Yeah.
See, generally for intraoperative period, we are using Cabalite or something like that. So I think they are preferred as crystallite, plasma light or something. So that works well.
We are using regularly the balanced salt solution for at least a pediatric surgeries or patients who are having metabolic problems.
Yes. So we are actually for all the surgeries, we are using balanced salt solution only. So we really stopped using RS and NS, and we are using plasma light or Cabalite only. So they work well, and so far there are no problems with that.
So pharyngeal catheter, Parna, the nasopharyngeal catheter that you were talking about, does it cause gag reflex in the patient if he's awake or partially awake during induction?
See,
But then that could lead to spasm also.
I didn't know about this study and I didn't know about this article till the time I started making the presentation. But I myself have used this for very obese patients at times. Not all the patients, but sometimes I do have used it. And sometimes I've used it along with the nasopharyngeal airway. So nasopharyngeal airway you put, and then you pass a small suction catheter to which you can attach the oxygen, and that always gave better oxygenation, I felt. So in very obese patients I have done that, but I didn't know about this article till I made the presentation.
You
But
didn't
it
get
works
any
well.
gag reflex?
No, nothing really, because it goes through the nasopharynx. And if you're so much worried, maybe you can just judge the like you can measure the nasopharyngeal airway, the length of the nasopharyngeal airway, and pass only that much distance so that the tip stays in the end of the nasopharyngeal airway, and that also would be more close to the larynx and the laryngeal opening. So yeah, it works well.
See, I started using those silicone one nasopharyngeal airways, which were very. But what I generally saw is that as the grade of obesity increased, they have a very less nasal space, especially nasopharyngeo-palatal space. And for 2-3 patients, I saw even that silicone going into the posterior pharynx for. Okay. So that is one thing that you can actually give a trauma to this patient. Then what happens once you have put it preoperatively, it is very difficult to hold the mask over it. The problem is that the length of that universal connector and the nose bridge mask, what we have is a Magill's mask, it is very difficult to fit, and there is a severe oxygen leak. And then if we are putting that, we cannot put another catheter over it. The reason is that there will be a lot of leak going in.
See, actually I've used it for scopies, like endoscopy.
Yeah, so for scopies and all, it's fine.
So those cases I have used it, and not for regular induction. In fact, regular induction, apneic oxygenation, I feel that even sometimes, the nasopharyngeal airway, when they are put, the mask leak is not that good. So that's another problem. But then with the newer masks, and you can inflate them well and all. So generally that problem is circumvented. But I have used the nasopharyngeal catheters mainly for scopies.
Yeah, for scopies it is advised.
Yes.
Okay, should we conclude, Bhavesh, Karna?
Yes. Thank you. Very nice, Nidhi, and all the topics were very well covered, like OSA and diet, and which we don't really hear much about, and optimization. So very good, very good.
Yeah, Swati, well done, very well.
Yeah, Swati's talk was very interesting.
Yeah, and Bhavesh, even your talk was very good. So
thanks everybody, all speakers.
OSA also was nice topic. Yes, thank you.
Thanks.
Thank you so much. Chalo, bye-bye. Let's conclude.
Bye. Bye, Manisha.
Bye. Thane is waiting eagerly for IMA results.
Yes, all the best to everyone.
रिजल्ट तो लग गया, अभी हमारे IMA के रिजल्ट का इंतजार है.
एक तो रिजल्ट लग गया थाने का.
मैं स्टॉप करूं क्या?
यार इन सचिवालय now.
Stop the record.
Yeah.
चलो, bye guys.
Good night everyone. Thank you.
Very nice.
Thank you. I miss Bhavesh's,
but I'll see it on YouTube after.